Вот так лучше? Первый доклад мой.
Уважаемые коллеги.
Ladies and gentlemen, dear colleagues, good morning. We proceed with the deliberations of our Congress, and to get started session with session number 13 on the treatment issues. And before we get started, I would like to introduce McDoherty, the director for the global programs of HIV, AIDS, and hepatitis. So the floor is yours. McDoherty, Mrs. McDoherty.
Good afternoon. Thank you very much for inviting WHO to chair this important session on HIV treatment. I'm Meg Doherty, the director of the global HIV, hepatitis, and STI programs at WHO in Geneva. And I'm particularly excited to be able to chair this session with my co-chair, Professor Gosov, during this session. We have 6 presenters today, and they will be speaking about areas of HIV treatment in the region, and it should be an exciting session. This year is important because we have the global AIDS strategy that has just been adopted. We have the WHO global health sector strategies on HIV that are under development that will take us to our goals for 2030 for eliminating AIDS as a public health threat by 2030. And we also have a high-level meeting on HIV and AIDS in June this year. So there is so much work to be done, but also an incredible amount of game changers that have occurred in HIV treatment. And we'll hear about some of those today. Some of the important things we have seen over the last few years include TLD, or tenofovir, lamivudine, dolutegravir as a fixed dose combination, which has been able to increase the number of people on treatment, as well as dolutegravir lower doses for children. And during the times of COVID, we have seen that these take-home medicines for longer periods of time have enabled people to continue their HIV treatment. So I will not speak more. We are asking that every speaker introduce themselves to save time. And we're also asking that you stick to your 10 minutes so that we hope after the end of this really important session, we have time for questions from the audience and or from those who are on the presentation panel. So with this, let me pass over to the first speaker, my colleague, Nicole Segu.
Good morning, everyone. I'm Nicole Segui. I'm the HIV, STI, and viral hepatitis team lead in the WHO Regional Office for Europe. So I'm going to share my slides. So there is an echo here. I think we need, yeah. My short presentation will be about ensuring fast scale-up of antiretroviral treatment in WHO European region. As you know, we had committed to elimination of HIV as a public health threat by 2030. We have fast-track objective, UNA's 90-90-90 targets by 2020 that are now expanded to 95-95-95 by 2025. And we have tools to simplify decentralized testing and simplify harmonized treatment regimen with more efficacious, tolerable regimen, as mentioned by Meg. On the right side, you can see the global cascade with 81% of people living with HIV who know their status and 67% of people living with HIV who are on treatment. Here, this is the cascade for our region. You can see that we have 78% people living with HIV aware of their status, but only 58% of people living with HIV who are actually on treatment. So we have a big gap in our region on ART coverage. We also have late diagnosis. In 2019, 53% of new diagnosed in our region were late presenters with CD4 levels less than 350. Those late presenters are more in the older age group and among people who have been infected through heterosexual transmission. We also had to face this year from 2020 the COVID pandemic. We've assessed the impact of COVID in our region on the services for HIV, particularly testing, treatment, and prevention. During the lockdown, the first lockdown in March to May 2020, and we looked at the speed of recovery after the ease of the lockdown. We found that the services that was most disrupted was testing, up to 50% decrease in testing during lockdowns last year. And the return to normal is really not even across countries. In terms of treatment, because we have less new diagnoses, we have less people who initiated treatment. But people who were already on treatment have been overall maintained on treatment, and this is a very good thing. In terms of prevention, we also had specific impact on disruption on prevention services. So what are the challenges to achieve the higher coverage in our region and particularly in Eastern Europe, Central Asia? We have delays in confirming HIV test result because we still use Western blot that delays the return of results. And we have a significant number of people lost before antiretroviral treatment initiation. We have late diagnosis, delay in ART for other reasons like stigma and long waiting time and various levels of quality of care. Rapid ART start is not universally adopted. We have also issues with cost of the best regimen, dolutegravir. That can result in poor retention. We have variabilities in frequency of visit and antiretroviral treatment dispensing, and a significant proportion of people who actually disengage from care. So what are the recommendations from WHO and the latest updates that can be useful to increase the ART coverage? The first is about moving away from Western blot. That is a recommendation from 2019. First, now WHO recommends HIV testing algorithm that use a combination of HIV rapid diagnostic test and enzyme immunoassay using a 3-test algorithm. Several countries are still using Western blot, particularly in Eastern Europe, and we need to move away from this old technology. Newer tests are highly accurate and can provide same-day diagnosis. And what are the shortcomings of Western blot? First, the interpretation is complex. Second, the indeterminate results are very common due to non-specific reactivity and cross-reactivity. There is a reduced sensitivity in early and acute infection, as you see on the graph on the right, and a high turnaround time with very high risk of loss to follow-up. So we need to look at possible ways to remove Western blot from our testing algorithm. And some countries have recently moved away, like Belgium, because of those reasons that I just listed. We also had in 2019 recommendation on better regimen and harmonization of dolutegravir-based regimens across population group, adult, adolescent, children, and also TB patient, and with changing evidence and also for women of childbearing age. We also recommend to move away from the efavirenz 600 milligram and use efavirenz 400 milligrams in our treatment regimen when we need to use efavirenz. We also have in March 2021, so this year, service delivery recommendation about providing differentiated service delivery for different type of patient living with HIV. I'll just go through the main updates and new recommendation. In terms of the clinical visits and the refills, WHO now recommends to have visits and refills every 3 to 6 months and preferably every 6 months if feasible. And we have tried during the lockdowns, during COVID, we have experience of longer refills. We did mostly 3 months because we wanted to preserve the drug we had, but if we can, we could go to 6 months. There is recommendation also on tracing people who have disengaged from care. We need to also integrate approaches for people-centered care, for including contraception, sexual reproductive health, diabetes and hypertension services, and psychological support within the HIV care to provide the best quality of care for people who need multiple services. So multidisciplinary team could provide a people-centered approach. This is just to reiterate that we have had more and more evidence that we should implement intervention to trace people who disengage from care. In our region, in some centers, we have as many people who disengage from care as the number who actually start ART in 1 year. We have a key population-driven epidemic with some population who have difficulties to come to the facilities. So approaches to find people back include remote communication through phone, text, mail, email, and in-person tracing, or combination of both. And it has been proven that we can have up to 60% people who re-engage in care with those methods. Recommendation also to simplify and harmonize the start of ART for people who also have tuberculosis, co-infected people. So the new recommendation is the ART should be started as soon as possible, within 2 weeks of initiating TB treatment, regardless of CD4 count among people living with HIV, except for those who have meningitis. This is also valid for adults and adolescents and also children and infants. This is based on new evidence balancing the risk of immune reconstitution syndrome and the risk of mortality. So this simplifies the approach. New recommendation also from March 2020 are dated, refined threshold and time for viral load monitoring. So viral load should be done 6 months after ART initiation and then 12 months after ART initiation and yearly thereafter. In terms of thresholds, for people with viral load less than 50 copies, they should be maintained on treatment. For those who have viral load more than 1,000 copies, they should be switched. And in between, they should have support for adherence counseling and retesting for viral load after 3 months, and so on. So it's a refined that was actually quite refined type of algorithm that was quite demanded by countries, and will have probably a better outcome with this algorithm. Now, diagnosis integration across program. We have experience of using multi-disease molecular platform to provide point of care diagnosis and avoid delays and loss to follow-up. We know that there is capacity within the TB program with the existing TB platforms to do also early infant diagnosis and viral load monitoring, and we promote the use of such platforms because it will improve patient outcome and timely result of various disease and viral load monitoring. Finally, this is the guidance that WHO prepared to face the COVID pandemic. So this is about maintaining essential services during COVID, not only for HIV, but there is an HIV section. And the recommendation were a long-pending recommendation in the existing WHO guidelines. For example, self-testing scale-up, and we have seen in our region significant self-testing scale-up that we need to maintain after COVID. Take-home doses of opioid substitution therapy, multi-month dispensation of ART and PrEP, and already talked about it. And also tele and video consultation and engaging courier companies and community groups to support home delivery of treatment, which we did very well in our region. There is also recommendation about restarting and catching up services when possible after ease of lockdowns. For example, catch-up prevention outreach and testing campaign for key population and catch-up of viral load testing, which we are doing in our region. This is my last slide, just to inform or reiterate that we have a phone application about the testing guidelines, the treatment guidelines, and also PrEP. And we wish that you know and that you use them because they are very hands-on and user-friendly. You will have the updated versions of the guideline only that they come. Thank you very much for your attention. And thanks to Meg and the team in WHO headquarters who actually works on the latest evidence and developed the guideline. And thanks to Elena, both from WHO European Office for helping me with this presentation.
Спасибо, Николь.
Over to
Спасибо
you,
за
Meg.
выступление.
Nicole, thank you very much. Thank you for your presentation. Thank you for your methodological help. Thank you very much. Dear colleagues, now let us move on to another presentation. Olga Latisheva, Inga Latisheva, the Deputy Head Research Center of Prevention and Treatment of HIV in Pregnant Women and Children. Women and HIV Issues and Solutions. Good afternoon, dear colleagues. It is my honor and privilege to see you in person. And now let me present my report, which is called Women and HIV Issues and Solutions. Our Minister of Health has said that this story is striking due to COVID spread. It is important that we have a chance to discuss our issues, our problems, which are really aggravated. It's hard to solve them, and they are extremely topical. The time limit for my presentation is brief. That's why I'll try to outline my topic. The HIV infection in women in the RF accounts for half of cases for those who are BLWH, and for new cases, you can see the data of the year 2019. Unfortunately, the data of 2020 is not accessible, but still, I think that the situation hasn't still changed on BLWH. Thus, we may focus on the half of people who are PLWH and who are living in the RF. Why do we pay special attention to women? 50% of those who live with HIV are treated this way. Sorry, there are some technical problems with the pointer. Let me move on to the next slide. I would like the pointer to work quickly. Well, we can see it. 40% of women live with HIV, and heterosexual women prevail in this group. Approximately 70% of women are sexually infected. As for women of childbearing age, there are 80% of them. And here the pathway, the sexual pathway, is even higher, and it reflects the HIV spread in the general population. Over 200,000 people are women who have children. They are mothers. What we are actually interested in terms of HIV infection in women, I'm in prenatal prevention. Never will we forget about it. In this regard, we focused on the importance of early diagnosis and timely medical checkup and early prescription of ARVT in order to decrease the risk of prenatal transmission. But this list of aspects is not comprehensive. Nowadays, over 350,000 women live in the RF with HIV, and these figures, according to the official statistics, fluctuate, but they do not increase. That's logical, because we see that approximately 50% of the newly diagnosed are women, and the proportion of women is even decreasing in certain time periods. What are the reasons for that? Our women have the short life expectancy. I mean, the women with HIV. Nowadays, women who are mothers, there are over 200,000 of them. The mother of each fifth child has a severe immunodeficiency. Let me remind you what it means. Severe immunodeficiency means that CD4 cells are there, and there are fewer than 200 cells when speed indicating disease is spread. It is associated with the suppression of the immune system. It contributes to the fact that these patients have high risk of death, and this risk will pertain, and it increases more than 20 times in the first years of life when it is diagnosed. And it also contributes to the fact that the life expectancy of this woman is short. We also have some studies on the HIV-positive mothers with severe immunodeficiency. These data have been processed preliminarily, since it's worth mentioning, and it's illustrative. You see that women with a severe immune deficiency are the following, and more than 50% of them have the critically low levels of the cells, 50 to 100 cells. As for prenatal prevention, of which we're extremely proud, we see that if women give birth to a few children and get chemo prevention and do not get the ARVT, these children are healthy. We can see the case of a woman who has 5 children, and 3 children were born when she had HIV, and all these children are healthy. It means that we have accomplished this task successfully. And what happened to this woman in 2020? She has 48 CD cells, and you can see the patterns of the disease related to HIV of the 4th stage, whereas the ARVT was interrupted after delivery. She stopped taking the drugs, and HIV encephalitis and cytomegaloviral infection was also diagnosed. And there were also some depression disorders and the metabolic syndrome in this woman. And this causes the decline in the quality and the life quality and the life expectancy. One of the reasons of severe immune deficiency in these women is withdrawal from clinical examinations, and many of them happened after the delivery of these women. Our women are multifunctional and multitasking. Still, they're also mothers. And first and foremost, they will care about women, and the children will be their top priority. And due to these conditions which accompany the after delivery case, the depression and stress, this doesn't contribute to increasing adherence. Each third mother has immune deficiency, and each fifth woman faces the AIDS stage. Let me remind you, what does AIDS condition mean? It's not only decrease in CD4 cells, but there are also some speed indicating diseases, which I presented here. They are like bricks of this house. You can see different conditions which were diagnosed. Cryptococcus, cytomegaloviral infection. I will not enumerate them. You are all aware of these constituents, which are part of the AIDS. The death risk increases fourfold, and psychoneurological diseases and cardiovascular risks also aggravate. But now we know how to combat with this. We have the rescue ARVT. This therapy increases the number of the CD4 cells. It's not always very effective, and sometimes immune deficiency remains. Still, we have this therapy available. When we constructed our house as AIDS, we put the basement, which was very hard to eliminate. It was practically impossible. The events which affected the men and women due to AIDS occurrence, it impacted the cognitive sphere and the nervous system. The consequences of AIDS-indicating diseases were also severe, as well as depression, anxiety. And sometimes we could see the occurrence of cancer. It is very hard to combat it rapidly. Sometimes women will suffer from it for the whole life. We can see the preliminary data of mothers who were diagnosed, and only 1/10 of them did not have any psychoneurological disorders. There is also a somatic pathology which was diagnosed in 90% of women, and these women are extremely young. They're over 30. We can see it nowadays in real life, and
You see no pathology as to 10%, and just 3/4 had the HIV encephalite. But as to the cognitive sphere, we see in here that only 1/4 didn't have any deviation from the norm, but about 50% had lower memory, lower concentration, and lower mentality status. And sometimes people tend to ask, why do they need extra memory and extra concentration? Maybe just for the sake of statistics, but let me show you some data as a result of questionnaires they filled up. And how did they assess their status as a result of ART administering? And they did it on a regular basis with no interruption. In 80%, it tends to be a quite efficient one, and only 1/10 say no to ART, and 1/3 of them have some side effects, and 37% are dissatisfied with the scheme. And actually, we have to view this from the angle of a physician and how these women assess their health status. And already 3/4 of women just showed some kind of phenomenon which were close to negative. 12% were suppressed by it. Some didn't actually abide by the ruling of ART. And they actually were quite honest, but some played tricks with us, but psychologists, psychoneurologists, cognitive status specialists had to assess their status. But women were not always committed to that mode of medications administering. And sometimes we are talking about subclinical and clinical depressions, and each second female may have this specific status. As to ART, they were subject to administering it, but 12 of them didn't get this therapy, but the majority of them actually interrupted this therapy, or it wasn't very reliable. And I would like to give you some kind of an extreme case. How can you be committed to IRT if some cognitive impairment is in place? And when they start reacting adequately, the female said that they, as if for the first time, saw their own child. And actually, females had some kind of a blurred mentality and blurred concentration, and they actually forgot about their children. And what are those schemes of IRT? And this is not how all the problems may be settled, as well as the in-depth deviations and impairment. And as to 50% of women, the protease inhibitors were administered to them in the course of IRT administering, and that may entail the side effects. And more than 70% had those side effects and some kind of related diseases. And in more than 70% cases are quite distinctive, and they interrupted the therapy. But nevertheless, we have to concentrate on that, and the inhibitors of protease is not the remedy for the majority of women, as it affects the central nervous system. And if we administer those drugs which do not penetrate onto barriers, so we cannot treat HIV AIDS this way. But if the penetration via DNA is in place, so that should be the inhibitors of integrase. These are high priority drugs, and that is raltegravir and dolutegravir, and these are special medications for adults. They have a high level of penetration via the barrier, and they may affect the HIV encephalitis. Let me say a few words about the efficiency of IRT. We're supposed to have a more detailed overview dedicated to that particular issue. So we talked about the commitment. We talked about the mode for administering of various medications. We have to overcome certain risks of the inflammation, especially that of liver, and it may bring about the hepatitis, and so it could be the initiation of aggression. It may launch the oncological processes. Therefore, we have to be really keen on the physical and mental health of our contingent, and prevention goes first and foremost. And the multidisciplinary approach turns to be indispensable as of today. This is the strategy we're talking about. It identified this method of treatment, and if children are born from HIV-infected women, should not be impaired. And of course, the comprehensive approach to the females giving birth to the child is the cornerstone strategy of ours. And our key goal is to retain the health of the mother and retain the health of children, even amidst the HIV infection. And 95% of them are born HIV-free. But nevertheless, there is still a problem, and we have to spell it out. Thank you for your kind attention. So we proceed with our deliberations, and the next speaker is Vasily Sigadyan, the Epidemiological Institute, Rospotrebnadzor. Mr. Chairman, dear colleagues, dear attendees to that conference and online delegates, and when we talk about the HIV-infected children and mothers, we couldn't just resort to the IRT or just to talk about the immunal status. This is a very broad-based issue, and really we have to speak about the criteria of the good health of a person having HIV. And thus we talk about HIV-infected women, HIV-infected children, and indeed we have to make a special program, and Leila Saimurova and Navaza Baranova talked about it yesterday. We need to program the health of children for the coming 1,000 days. Originally, it starts from the medical examination of the HIV-infected women. They have to visit our centers. Maybe rubella antibodies are to be identified, and vaccination could be an option. And rubella seems to be very contagious and may bring about the pathology of children. And so we also have to think of the inherent infections which may hit the embryo of the HIV-infected mothers. So we have to think of children first and foremost. Inga Borisovna talked about it, but we have achieved great success in the field of the prevention of the vertical transmission of HIV. And I represent the center as well as Inga Borisovna's center. Spare no effort as to making a progress in this field. And in 2019, more than 190,000 children were born from HIV-infected children, and those infected constituted 52,066. But 138,000 were born healthy. But the question arises, to what extent they were healthy? And over the past few years, we've been discussing this problem quite often, and Mrs. Ladin and Mrs. Kazirina talked about it. And in 2018, 15,000 children were born. In 2019, 13,000 plus. But in 2028, 132 children died. And in 2019, it was 91 out of those born from HIV-infected mothers. But in 2019, only 5 were HIV-infected. What are the causes for the death of these children? And we may only give some data of our centers, thus formulating the reasonable causes of such lethal effect. And this becomes absolutely indispensable for us. And you, dear colleagues, represent your own centers. You know the frequency of some problems with among children having HIV-infected mothers. What is the cause for newly born dead babies, and what is the cause for neonatal losses for low weight children, and what is the problem with children's disability. Academician Baranova told us yesterday that infections cause the disability of children. What about the numbers you may cite, and can you just give some definite number of these particular effects and diseases, and what are the measures to mitigate this effect? Everything in the Russian Federation is somewhat disorganized and not at all harmonized, and we cannot have these statistics, what happens from the moment of inception up to the birth of children. We do not have these aligned statistics, and the perinatal mortality rate is by 2.5 times higher, and in 18 and 19 it has become 2.5 higher, and the coefficient for the perinatal mortality is much higher, and that has nothing to do with HIV. And in Russia, this statistics is somewhat higher than that in the Western European countries.
What are the reasons for this situation, dear colleagues? Which actions are we going to take? Are you aware of similar figures in your countries and in your regions? If the infection is the cause for early death of children in general population in 3.4% of cases, but if the mother is HIV infected, the rate is much higher. And we believe that one of the most probable reasons of this increased prenatal losses is a high neonatal mortality. It is caused by congenital infections which were not detected by pregnant women because these babies, these newborns, are not examined. Let us take the general rate and at least 100-150 babies could have suffered from congenital infections. Let me reiterate that reliable data is the following. The reliable data on intrauterine infections in the children of HIV-infected women in Eastern Europe and Central Asia and Russia is absent. The number of babies who were born who are HIV-infected. Still, there are some cases are not known. In Moscow, in St. Petersburg, or in Kazakhstan, we cannot tell you exact figures. Etiology of the disease in the first days of the babies is not deciphered. You diagnose with pneumonia, with COVID-19, perinatal, central nervous system damage, and no one can detect the delayed consequences. And also such diseases as palsy, autistic spectrum disease, epilepsy. You are not aware of these figures. Etiology of the disease when the baby dies is still unknown. People note either COVID-19 or pneumonia. It means that you do not review your errors and the problem isn't still solved. Modern diagnosis, algorithm of examination of pregnant women and babies are not implemented in the real clinical practice. There is no accurate criteria for obstetrics and neonatologists, obstetricians, and gynecologists. And we are not discussing the measures aimed at changing the situation, altering them. We see that the rate of congenital infections in children is higher than women. It's 3.56%. This slide shows that these infections over in 2019, we see that more than 13,000 children were born. Almost 100 babies will be infected, and 90 of them will have neurological implications. In 10% of cases, if the infection is asymptomatic, the children will have such disorders as schizophrenia, cerebral palsy, and autistic spectrum disease. 100 and 130 children could have been affected by these infections. Although they are not HIV infected, they have severe infections. They are not healthy. Let us look at the data of Kursk Center. Out of 3 babies in the intensive care units, some of them died, and only one of them was HIV infected, and others had congenital diseases. And I focus on psychomotor retardation. They are not capable of studying, although there is no Down syndrome. We can see the other diseases. No one knows these figures related to these babies. There are 10% of cerebral palsy and 10% of autistic spectrum disease related to this infection. We can't just ignore this information and smile, but if you can see this child who's hard of hearing, hard of seeing, and has some disorders, and who is 12 years old, and whose mother is HIV infected, she gets ARVT. She is not HIV infected, but we can see the delayed consequences. We cannot claim that this child is healthy. We have a chance to diagnose congenital infections in pregnant women in order to protect the children with corresponding treatment, and our work shows that we can define the specificity and the sensitivity of each laboratory factors such as antibodies. The DNA in the cells of pregnant women has an unfavorable significance, and we can also see some data on genital infections, listeriosis, paraviral infections. It requires more precise information on diagnostic algorithms which should be used in pregnant women who are HIV infected. We shouldn't just pay attention to ARVT. If we are aware of accurate parameters of acute or active infections in pregnant women, we can see the data on this infection. We will not only use pseudo drugs, we will also use these ethiotropic drugs with antiviral effect. It is very easy to prescribe corresponding drugs if you're aware of the criteria. It's not only immunoglobulin, it is also another drug such as valaciclovir and some other drugs. Concurrently, we will have the accurate criteria. We can also relate to, it can also be related to cytoplasmosis. We ought to treat women. If we know that HIV-infected pregnant women had some problems in congenital infections, we may set the criteria in accordance with which we should diagnose babies in the first days of their lives. They should not only be examined for HIV DNA, but also for other congenital markers of other infections which may affect their health. We can see the accurate criteria on each infection. Such as cytomegaloviral infection, there are some accurate criteria which will allow us to diagnose the infections, such as cytomegaloviral infection of newborn babies, and will also prove that congenital disorders are related to infections. You can see the criteria of intranatal infection. This criteria allow us to prove that the diseases of in CNS, colon, and lungs is not related to intrauterine retardation. It is related to perinatal diseases. It's not related to these diseases. It's related to particular infections which require antiretroviral treatment in order to save the babies' lives, and in order to provide high quality of to babies' lives. Although they are not HIV infected, they may suffer from other infections and other diseases. We will never diagnose the asymptomatic cytomegaloviral infections in women. We will not use this therapy, and the babies will not die the age of 2 or 3. We should understand that children do not have any cognitive disorders. Nowadays, one of the most probable reasons of aggravating the health of babies and high perinatal losses is the higher rate of congenital infections in HIV-positive mothers' babies. Not all the problems are related to these issues. Still, we should clarify the situation, at least in the RF. We need reliable data on the morbidity in all the intrauterine cases in neonatal babies, if the mothers are HIV infected, we need the analysis of reasons, the spectrum and the rate of congenital pathologies, as well as disabilities in children. In order to prevent it, we should understand whether it is topical or not and what we can actually do. We need pilot studies in one of the regions of the RF. It has been planned by the Central Service of Epidemiology and the Federal Center of the AIDS. It is planned in one of the regions of the RF. This study will allow us to define the role of the intrauterine infection in the morbidity and the mortality of children. We should not be limited with the viral load. We will achieve normal immune system indicators in pregnant women. It is expedient to implement the diagnostic algorithms in order to diagnose active infectious pathologies in women. And we should use sensitive and specific laboratory methods which will allow us to answer this question. This we will understand whether these pregnant women have infectious pathologies or not, as well as babies. These children should be provided with etitropic therapy. It is impossible without diagnosis. It is impossible to carry out this treatment in the antiretroviral effects without diagnosis. Our involvement in these high-level conferences and our meetings should be effectuated in the amendments in the documents. It should be related to management of pregnant women who are HIV positive and their children. We hope that the algorithm of examination of these children and their babies should be included in the algorithms of diagnosis and treatment of intrauterine infections in order to decrease the perinatal losses and to decrease the baby mortality and to provide high quality of life of our babies. Thank you very much for your attention. Thank you. I believe
First, that we should
действовать, в том числе и с
only
Ингой
10 minutes for our
Борисовной, с Евгением Евгеньевичем
presentation.
Ворониным, да, и
Thank you.
разработку это единый документ, регламент.
And so we have to have a uniform document to curtail the HIV infection plus opportunistic ones we've been discussing. Thank you for your kind attention. A very interesting presentation. And Елена Валерьевна Цыганова, the senior specialist for HIV infections for Ministry of Healthcare in the Central Okrug and the head of the clinical department for HIV/AIDS prevention. The floor is yours, Елена Цыганова. There's no sound, no sound, no sound, no sound. There's no sound. No sound.
Okay.
We are not hearing your presentation.
No sound.
Валерьевна.
No sound. Звука нет. No sound. Звука нет. Yes. Yes, we can hear you. Now we can hear you. Thank you. Sorry for some technical malfunctions. The clinical recommendations presuppose a document based on the objective data for structuring information on the prevention, diagnostics, and rehabilitation, the protocols of the patients, and medical interference, and the plan of treatment, and actions of the physician. Also related diseases should be taken into account, and some other factors of the medical aid. Let me remind you that clinical recommendations are based on the principles of proven evidence, and that should be also confirmed by the professional and non-commercial organizations. And in the past, we didn't have any harmonized recommendations, and various NGOs could have developed their own recommendations per disease, and formats were different. And from the perspective of the legal regulatory framework, all the clinical recommendations were absolutely equalized. And it was really hard to find some common denominator so that to provide assistance to our patients. And the Ministry for Healthcare didn't affect the development of the list of that recommendations. So we didn't have any uniform approach to the validity of this data, and there were no requirements for the frequency of review of such recommendations. Nowadays, the professional NGOs are fully in charge of these recommendations, and they are further on reviewed by the R&D Council of the Ministry of Health, and that should be one clinical recommendation per disease for children and adults, and it has to be reviewed at least once within the 3 years period. This particular slide shows the federal law number 323 on the fundamentals of healthcare. Yelena, we do not see your presentation. Could you just download it onto the screen? Is it visible? No? Yes, that's it. That's it. Okay. And this is Article 37 of the Federal Law 323 on the fundamentals of healthcare protection in the Russian Federation, the organization for rendering medical assistance. And medical assistance, with the exception of clinical probation, should be provided on the basis of the following. It should be reviewed as of the 1st of till the 31st of December. And we have the ART drugs, which are registered last year. This is tenofovir alafenamide, doravirine, and all those combined ones. Bacteriacravir, tenofovir alafenamide plus M3-citabine, cobicistat plus tenofovir and dovirin. And this is what we have in the list of new drugs. And the HIV infection for adults is a standalone block of recommendations. It is presented on the site of the Ministry for Healthcare, and the national virus association plus the prevention of diagnostics and HIV infections treatment is presented on PDF, and this how this document looks like. I'm not going to dwell upon the contents of this document due to the time limit. This particular slide presents the comparative analysis of ART for adults and children. And we have a comparison for clinical recommendations of 2020. What has been added since then? And we have some schemes which are preferable ones from non-nucleide inhibitors. And also we have the inhibitors of and we have alternative ifovirian, 400 milligrams, and for some particular cases we have some combined options which had been registered just recently, and these are ARTs who could not administer those preferable ones. And it is all done with due regard to the recommendations of 2020. Though we have some combined drugs having the third component, the viltegravir, the inhibitors, and taravirin. And how do we combine and compare, make a comparison of these newly administered drugs with regard to the recommendations of 2020? ART drugs will be placed onto the second tier, that will raltegravir, inhibitors, and atazanavir and gronavir. And as alternative, the whole list is included in the drugs of the first aid for the Russian Federation. And we have some reduced schemes for IRT. We have DTG plus 3TC, but the combination of factors define this particular drugs administering, and there should be no clinical signs of some secondary diseases, no resistivity to the inhibitors of integrase, and less multiple resistivity, no hepatitis, and no pregnancy. And let me draw your attention onto the block which is absent in the recommendations. That is the post-contact prevention at the level of medical staff. And the preferable basis recommended is TDF plus 3TC or TDF plus FTC. And the preferable third one is DTG, and if it's accessible, that should be ATVR, DRV, LPVR, RAL, and they could be placed as an alternative ones. And the testing for antibodies to HIV should be provided in the emergency situations and also within 1, 3, 6, 12 months after the contact. This is actually the end of my presentation. Thank you for your kind attention. We proceed with our deliberations. Dinara Revnatovna Nabiulina is given the floor. This is the Moscow City Center for HIV/AIDS. Dinara Renatovna, the floor is yours. Good evening, good day, dear colleagues. I need the screen demonstration. Yes, do you see presentation on the screen? We can hear you, but no presentation yet. Okay, I would like to present my presentation, the HIV treatment for women able to give birth to children. And so 44% in out-of-patient clinics were inspected, and in special consultations in the HIV and in the AIDS center, it was 3%. And normally, these are women up to 25. We have the comparative analysis for various regions brought, and the Russian Federation of the fertile age are presented here. It's 3 to 1. The average age is 30 to 45, and these are sexually transmitted diseases. Heterosexual contacts, homosexual contacts presuppose 2%, and intravenal it takes place at the level of 44%. And what is the dynamics for infection transmission in Moscow? Women have the predominance of heterogeneous infections as opposed to intravenal. And we nowadays have a higher level of infected people over 30. And we also have the HIV identified at the level of younger generation. HIV infection may affect all the periods of women's age, and normally men create a problem as opposed to women. And actually, we do not have much information and awareness of the situation for HIV. In the Russian Federation, 40% are those HIV infected are women, but they may have the higher level of ESD4 cells and lower level for RNA HIV than men. And the criteria for the initiation of therapy for non-pregnant women are just the same as for males. And women from 17 to 30% are included in that comparative analysis. We have more data for males than for females. We are guided by the law 323 and article number 37 on the medical aid provision, and that is number 3 provision on the basis of clinical recommendation. This treatment will be provided, and this article will be enacted as of the 1st of January 2022. And 489 law prevails here as well. As to the new clinical recommendations for HIV infections for adults, so we have this list of recommendations. And if women are pregnant and if the lab test showed HIV and due to the vertical transmission, so the treatment should be launched, and some clarifying results could be necessitated. And we really have to prevent the vertical transmission, the low level of HIV transmission to embryo from mother. So we have to take into account all kinds of preventive measures, and also we have to avoid the ART effect onto the embryo. And we have some recommendations for the launching of the treatment if it is 28th week, and as to IRT preparations for fertile age.
In new recommendations of the Ministry of Health of the RF, it is stated that it should be prior to indication of dolutegravir. This may result in the deficiencies of the nervous tube of the fetus. It has proven the safety while using in pregnant women, but the risk of occurrence of these deficiencies is high. If the gestation term is fewer than 9 weeks, we should substitute the antiretroviral therapy regimen. Lopinavir and some other drugs are used. Over 80% of women would like to have more children in Russia. Here I will refer to discordant pairs because discordant couples and 90% of HIV-infected couples are discordant. They have been having these relations 1 to 5 years in 56% of cases. ARVT should be indicated in order to prevent the transmission of AIDS from infected patients to non-infected partners, and prevention of prenatal transmission of HIV from mothers to children should also be prevented. Let me focus on the order of the Ministry of Health of RF, which was enacted on the 31st of July. It's about the using the reproductive technology, indications and limitation to their use. HIV infection in discordant partners is the following. It doesn't depend on the status of fertility, and this point is not mentioned in this ruling. And there are some kinds of HIV infections which are not the indications, the counterindications to medical assistance. And the point 3 is the exception when the medicinal products are indicated. The drug interactions should be considered with the interaction with the antiretroviral drugs. And it doesn't depend on the indications to HIV infection. And if a woman becomes pregnant, the RVT treatment should be provided during the whole gestation period. Here are the diseases associated with AIDS, with HIV at 1, 2A, 2B HIV infections. It is recommended to delay the RRT prior to the subclinical stage. It lasts at least for at least 6 months. All the patients should receive the RVT if there are no counterindications, and the viral load should be less than 50 copies per milliliter for more than 6 months. This slide shows the figures on the use of reproductive technology in HIV patients in our center. The analysis was conducted in accordance with the medical reports. These patients are planning to participate in reproductive technology programs. On an annual basis, we see the increase in the issue of medical reports. In 40–50% of cases, the technology is not used. Maybe we lack the data in 40% of cases. Sometimes we don't have any data if the man is HIV infected and his partner, the woman, is not HIV infected. Thus, this technology is not applicable. As for the number of labor and children, we can see the data. We can see positive results. On an annual basis, the number of labor and children increases thanks to additional reproductive technology. Here is the indication to carrying out the additional reproductive technology. We see epidemiological indications and gynecological indications when the couple is discordant. As for the AIDS, the HIV stages, most of our patients are on the 3rd stage in terms of using this technology, but some of our patients take medical reports with when they suffer from the secondary stage of the disease, and this stage is higher. Over 200,000 children were born by HIV-infected women. The number of labor of HIV-infected women was more than 13,000 in 2020. This doesn't differ from this year. And since 2001, we use the protocol 076 about the prevention of perinatal transmission of HIV from a mother to the child. ARV chemo prevention was provided to more than 12,000 pregnant women. It was 94% in order to decrease the risk of transmission of HIV to a mother to a child. We should focus on the adherence of to treatment. The drugs with fixed combination of doses should be used, and these drugs are authorized for use in Russia. We have 12 doses, and 2 of them can be purchased via the federal programs. It is free of charge for our patients. Definitely, when we prescribe the drugs, which will be part of the treatment regimen of women who are planning to become pregnant or pregnant women, we consider the information on the drugs. We also consider the data on using these drugs in pregnant women. An important tool is the International Registry of ARVT during pregnancy. On an annual basis, the data on 1,500 pregnant women is included in this registry in terms of using ARVT. It is also worth mentioning that all the drugs for our patients are bought via the federal program. You can see the form of the federal report accordance with the ruling of the government of the RF, and they are for women of childbearing age. Concurrently, we may also consider the opportunity to purchase the drugs for pregnant women, for babies, and we should indicate the number of patients and the treatment regimen. 50% of women interrupt treatment after labor because they care about children and they don't have a chance to arrive in the center. What are the possible solutions to the problems? They use using the telemedicine technology and drug dispensation for 6 months. Now it is possible. Another important issue is the fact that 77% of HIV-infected women suffer from cervical neck cancer and some other kinds of cancer. Vaccination is important. Another key issue is the following. When we conduct the ARVT in HIV patients, we should consider the interaction between drugs. We mean hormone and contraceptive drugs. Women can be on treatment. We have the Liverpool website where all these interactions between drugs are represented. In conclusion, let me highlight that it is of prime importance to carry out safe and efficacious prevention in order to prevent the progression of HIV infection and in order to prevent the cervical neck cancer and the transmission of HIV from a mother to a child. If a woman is on treatment, on effective treatment for a long time, the baby is also prevented. We lessen the transmission of the virus from the mother to child, and we would like to eliminate it. Thank you very much for your attention. Dinara, thank you for your interesting presentation. We have one more presentation, Anna Derabina. Improving adherence to HIV treatment through home care in Central Asia countries. Thank you very much. Yes, I am Anna Derabina. I am the Regional Director for Central Asia of the ICAP organization. We are part of the Columbian University, and we have our own branches in 3 countries of Central Asia. Our key work in Central Asia is aimed at HIV infection programs, and we also deal with infection control. Since 2020, we have been involved in the COVID-19 programs, and our today's presentation is dedicated to our program, which we have been implementing since 2020. Jointly with the Centers of Family Medicine, we improve the adherence of the patients to ARVT. This program has some key focus groups. The patients who start being treated start the ARVT for the first time, and some of them have already received ARVT for 6 months, for at least 6 months. But due to poor adherence, they didn't manage to achieve viral suppression. Last year, we also involved the patronage of pregnant women who receive ARVT regardless of the viral load and their status. This program has been implemented since 2012. You can see the regions in which we are currently working. The program was launched in Pavlodar and Eastern Kazakhstan region in 2018, and then we understood that this program is effective, and it was also widespread in Kyrgyzstan and Tajikistan. What is the crux of this program? We have the standards of medical assistance provided by AIDS Center and the Centers of Family Medicine. All the people are treated by nurses. They communicate with nurses who conduct the patronage calls and visits for 6 months. These visits and calls are structured. They comply with a certain schedule. For the first 3 months, they visit them on a bi-weekly basis, and then they visit them once a month. And the nurses call the patients in order to clarify whether they're in a good condition or not, and the nurses also find out whether they have any problems or any questions. The informed consent of the patients is required. The nurses or the doctors inform the patients of these programs. They dwell upon the program of interaction and the requirements for the patients. The visit procedures are described, and if the patient agrees, he signs the informed consent form. Then the doctor transfers the data to the nurse. The nurse will work with this patient, and then the nurse calls the patient, and they agree upon the date and time of the visit and the place of the visit, and the visit schedule is compiled. It should be convenient for patient visits. The visits take place at home or at some other places which are convenient for patients. Originally, we planned only home visits, but then we realized that some patients refuse to accept to welcome the nurses at home, especially in the rural area, in order to avoid some extra questions of the neighbors, because although nurses do not wear any special robes, special clothing, sometimes they meet at the neutral territory, at parks or workplaces and some other places. Each visit is structured, but on the whole, the nurse collects the complaints of the patient, assesses the patient's condition, measures the temperature, the pressure, tracks the occurrence of side effects, and questions the patient for tuberculosis symptoms. The nurse also calculates the number of the tablets and collects some information on the adherence. In the course of the first visit, the challenges are discussed by the nurse and the patient. These challenges are related to ARVT, and then they elaborate the certain plan for resolving these issues. They also work with their partners. If this person lives with a partner, some of the family members may also be involved as assistants in treatment. It is observed in discordant couples. They also discuss whether they have a chance to reveal the status to the partner. Some alternative methods on organizing testing of partners for HIV infection are put forth. When we face the COVID-19 situation, the delivery of ARVT drugs was also carried out by patronage nurses. Over 300 visits for over the last year were related to the delivery of antiretroviral therapy drugs. They were dispensed for 6 months in Kazakhstan. Still due to transport limitation, this reserves for 3 to 6 months should be transported, and nurses were actively involved in it. This approach is structured. A special electronic mobile app was devised, and it contains the information about the nurses' work, and the doctors and patients, as well as the nurses, exchange the information. The visit dates and the workload are documented in this app. It also includes the data on the condition of the patients. The visits may also be confirmed in these apps. It allows us to ensure that the nurses not only communicate with the patients by phone, and the information is sent to the mobile phones of the patients, and then the information is included in the program to ensure that the nurses gave the full volume of the information.
И распечатаны вот такие вот флипчарты.
And printed out some flip charts for pregnant women, for breastfeeding, for those cooperating with teenagers, and for the general public. And those flip charts are used by the nurses in the course of the discussions with the patients. And by the 15th of April 2021, we had 75 nurses to take part in that program from 30 medical institutions with a coverage of over 6,000 clients. The program completion took place at the level of 4,405, and 949 patients are still within the program. And those patients who withdrew from the program with the viral load lower than 1,000 millimeters, and those who didn't show the efficiency of IRT constitute 78%, and those studying IRT constituted 92%. And we had a more in-depth analysis of all the data and realized that as of the next year, we have to get focused on the second group, having some failures in the treatment. A part of the patients without any external help may be quite successful in their therapy, and therefore the program includes those who already have some faults in the treatment process. And those who are subject to the therapy and those who had some problems, and about 2/3 complete the program. And what is going on with the remaining 1/3? We have from 11 to 20% of those who say no to the program. And as to the patronage and home nursing program, people do not want to disclose their status. They do not want to communicate. Though people want to relocate, and actually they do not sign up for this 6 months program. And from 8 to 16% withdraw from the program just unexpectedly due to migration, little effect, seizure, and actually the person may be excluded from the program due to the aggressive behavior. And we may say that nurses may become threatening, nurses' visits may become threatening for their health. And these people are also excluded from that list. Hereby, we see this breakdown for females and males without virus suppression for Tajikistan and Kyrgyzstan. But as for men and women, it's about 78 to 80%. And it's good news that we haven't noticed any problems as to the injections of drugs and non-injections of drugs. And we couldn't identify 100% whether they consume them or not, but we just looked through the anamnesis and compared the data. What are those key takeaways of that program deployment for home nursing over the past 3 years? This program promotes the virus suppression of patients onto the IRT having very high viral load. And also, we have a higher awareness and getting the higher skills and habits and competence for the medical nurses. And the status of the medical nurse became higher, and there were quite a number of functions upon consultancy which was provided by the nurses. And we actively trained our nurses, and they now know better what kind of consultancy services they may provide, and they felt more comfortable. And I do hope that this program will go on progressing, and we will be improving it and embedding it. And I would like to express my gratitude to the medical staff, to the patients involved in the program, and to the Republican, regional, and city centers which do support this particular initiative. And of course, I would like to thank those sponsors, PERFAR CDC and Fund on AIDS, combating, named after Elton John. And you had a very interesting presentation, very interesting deliberations. So we are already exceeding our time limit, 6 minutes plus. And so I would like to thank all the presenters and for the quality of your presentations, for those materials and documents which you resorted to. My dear co-chairman, would you like to say something in conclusion of our session?
Professor, I would like to thank you very much for having WHO co-chair this session. We've learned quite a bit around the treatment protocols and treatment successes that are occurring in the region. We would be very interested in engaging with our colleagues around how we can bring both the fixed dose combination, one pill once a day for simplicity, and also ensuring that pregnant women have access to the best regimens possible. We have learned over this past year from WHO, over the last 2 years, that this risk of neural tube defects has really gone down to a very low level risk. That's why now we recommend using dolutegravir around the world during pregnancy and even in early pregnancy. So, however we can assist with ensuring that every woman, every child has access to the best regimens, we would be very, very welcome and excited to do that with our colleagues. Again, excellent presentations. And with your permission, we can close this session as I don't believe we have time for questions and answers. Thank you very much.
Спасибо.
Thank you so much. Denis Alexandrovich, if you allow me to, I would like to thank you for your wonderful chairing of the session. It was a very friendly atmosphere and very demanding as well. Much depends on the chairman, and it's our honor and privilege to have you presiding over this session. Thank you once again, dear colleagues. I wish you all great success, interesting communication, new information, and have a good day. Bye-bye.
Случайно увидел? Как вы?
Ну, вот я 5 лет возглавлял сейчас в больницу был.
Я успел почитать. Я возглавляю спеццентр республики.
Ну, отлично, давайте будем на связи.
Ваши не молитвы, до рассвета. Как у вас? Все нормально?
Все в порядке. Появился, правильно. Как целом, собственно.
Будем ваши проекты забудем. Я обязательно зайду к вам. Я уже
Сейчас начнется конференция.
да, уже, дай бог.
Приезжайте к нам, у нас мы очень хорошие, уже 5 форумов проводили по вечерам.
Я в Буркине админскому году Ладно, спасибо вам.
Удачи.
Она вчера выступала. Она и сказала именно, что вот тысячедневное программирование за рубежом. Она взяла 200 дней индивидуального развития и 2 по 365. Я полностью открыт. Давайте сейчас мы обкатаем протокол чисто теоретически, да, с лабораторной службы моча, да. Оказывается, ее надо сначала обработать, там, чтобы на то есть не так все просто. Сколько надо храниться, как она должна поступать, это технически. Что мы хотим хотели протокол написать для страны СНГ, но это политически конечно. Да, ну тем более Санкт-Петербург, это уж вообще, как говорится. Более того, Денис Александрович просто на таком пекле оказался. Ну вы прекрасно знаете, вы меня никого не трогал, конечно.
Тут одно и второе сразу.
В один день, конечно. Да не, ну, понимаете, она как-то вроде бы по общему что-то чуть поменьше, но тяжело много. То есть я уже третью не может открываться. И они все забиты. Значит, освобождается место, помыли, что дезинфицировать, и же раскрыть.
То есть отделение количества у вас осталось? Давайте я вам сейчас ушло, пока пока сканер обратно. У нас самое главное онлайн.
Нет, вся пискаревка зарегистрирована. Вот а сейчас кишка пошла, гепатиты пошли, борты, как бы они держались.
Знаете, что я сказал, что мы отмечаем сепсисы, воспаленные такие, вот даже причем через 2 недели, то есть какие-то вот даже отдали не просто вот на октябре там, а...
Да нет, на октябре как раз таки мы не видим.
Да, а вот какие-то странные, которые с кишечника стерилизации.
Вперед нас.
Очень много пчелы в разных зеркале. Вот если это не выписывается, через неделю, через 2, особенно пожилые, уже поступают тоже на междородскую кишку, с тяжелыми, с септическими, конкуррентным резистентом. Я еще в октябре вакцинировал. Да, я родитель получил. В основном пожилые коллеги. Вот сейчас вот у нас все, ну даже не 65, а 75. Не было в некоторых центрах, нет. Ну почему? Мы же отвечаем через СМС. Там был небольшой перерыв культур до нуля, чтобы сказать, что вообще в городе не было.
Вы записывались по госуслугам? Сказали, нет, нету. Мы написали жалобу.
Целый зам руководитель.
Мне интересно, мне из департамента Concurrent Session ну, якобы мне не очень срочно было, думаю, ладно, посмотрим.
Ну сейчас пришло и корона, но мне не нравится. Мы привили, после 60 лет вообще не кормят. Да не, ну у нас вот эти вот пептиды, там, понимаете, это, как говорится, без вируса сделанная вакцина. Ну вот я еще раз говорю, у нас такое вообще негативное получилось.
А у вас вы реаниматологов новых берете, да?
Конечно.
То есть это тоже целая проблема.
Слушайте, ну вот, когда разворачивали койки в первую волну, так сказать, тогда было проблематично, потому что народ не принимал что-то и так далее, еще денег не платили, а сейчас отбоя нет. Сейчас отбоя нет. Вот мы последнее отделение открывали на 18 поезд. Значит, неделю набирались персонал. Ну, они денег еще заработали. Они зарплат больше не дают. Все набрали ипотек, все
Ну, конечно, сейчас.
сидят, лишь бы ковид не закончился. Хоть бы годик еще поработал.
Поликлиника тоже не ждала, сам к этому в этот день.
Да, хотя бы один стол был.
Что куда делся?
А у нас же еще губернатор после 100 тысяч заболевших.
А врача?
Медицинская работа. Вы стали ловить, у нас же камеры есть. Стали
если легко прям. Но это мне рассказывали, что как-то женщина.
Сообщение у нас начало. 11:45.
Что женщина специально заражает
Мракобесие, конечно.
Да, да.
Так, мы ждем, получается, Елены Борисовны. Так, еще Нина Тимофеевна. А Нина Тимофеевна?
Ну, Тимофеевна нет, да, да. Давайте мы уберем табличку человека.
Ее не будет, да?
Точно не будет. Да. Александр Александрович, вы, наверное, будете вести, вы у нас главный сегодня. Мы будем вас слушаться. Дирижерской палочкой нас, пожалуйста. Организуйте нас. Да, как-нибудь нас, да. Так, вы здесь, ага, ну, еще не знаю. Да, это нужно удобно.
Девочки, кто из вас табличку?
Я еще, знаете, что хочу? Потом вот мне с вами телефону, это что хотела вам написать, вы где? Я уже пофиг попила, уже нашла уже Артема, где он там сидел. Поэтому... Но у меня...
Да, чтобы девушка,
она же не... Потом... Ну, типа так, да, да.
так,
Как
нам
кочка.
нужна Елена Борисовна. Вы пометили себе что-нибудь?
Ага. Да, давайте я вам сейчас... Это долго?
Тихоновой, да?
Тихоновой.
Да, все, ее не будет.
А, то есть доклада не будет?
Да, да. А Елена Борисовна не будет, да? Нет, ну я так поняла, что да, вы сказали.
Елена Борисовна.
Да, Елена Борисовна. А нет, Елена Борисовна...
Нет,
я табличку
Бешова,
убираю.
Бешова, да.
Я как это, я просто...
Так, Елена Борисовна Жлова не будет, да?
Нет,
Она как бы, не знаю, но...
не знаю.
Сейчас, да, мы пока оставляем.
Тихоновой.
Тихоновна. Докладчик.
Да, докладчика.
И доклада тоже не будет?
Да, доклада тоже.
Или может что-то
Но
было?
но мы это самое, мы сделаем так, что мы по времени все у нас будет нормально.
Так, тогда мы ждем Елену Борисовну, и, собственно, мы можем.
А вы что знаете?
Она будет, да, Елена Борисовна?
Надо сейчас...
Ой, у меня листочки куда-то девались. Можно ей позвонить.
А у вас есть контакт? Просто у нас, к
Давайте я позвоню ей, Борис.
У меня нет... Куда мне звонить? Ее не будет. Да, вот сейчас только что. Нет, она была вот только что.
Здесь уходит Алексей.
Вот. Вот это вот беременная, я ее не
Не будет, да, Елена Борисовна, еще?
Не знаю, сейчас пойду.
Ну, если будет, наверное, тогда она присоединится, предлагаю начинать, потому что будет список, что-то на самом.
Сейчас я попробую позвонить.
Пожалуйста.
Я вам сейчас
Алло, Елена Борисовна, добрый день. Да, Елена Борисовна, вы как? Вы к нам присоединитесь на Конгрессе? Нет, ничего, просто вы там председатель. Тогда мы без вас начинаем. Все, да.
Ничего не будет, да?
Да. Все, Елена Борисовна, отдыхайте, да. Ой. Хорошо, до свидания.
Вы дадите нам отмашку, когда будете готовы, мы, собственно, тоже готовы и можем начинать трансляцию.
Ольга Борисовна в отпуске, поэтому вообще мы отправляемся за вашим.
Как, тогда мы
Добрый день, участники.
Good afternoon, dear attendees to the section number 17. We are supposed to discuss an issue on vaccination, and national calendars for vaccinations are in place. And we start forgetting about various infections, but it will be really worthwhile to follow presentations on the prevention of measles, poliomyelitis, and the COVID-19 infection. And the coronavirus was a new challenge for us for 2020. But thanks to measles, when it started being exposed 2 years ago, so we were prepared for vaccination, especially at the level of the Republic of Belarus. And we have managed to talk about the preventive measures and started some anti-pandemic actions. And we have Patrick O'Connor on the online mode, and he is the one to talk about vaccines, and he is going to speak about the elimination and control over Europe for WHO. The floor is yours.
Не слышно.
Sorry, we can't hear you. Just one minute, we will tune you in. Can you hear us? Can you hear us? Can you hear us? Okay, you may start talking.
Да, вас слышно, слышно, да. Все окей, слышно.
It's okay? Okay. Lovely, thanks. So thank you very much, and I really appreciate the opportunity to be able to give you on vaccine prevention. I'm from the WHO regional office based in Copenhagen, Denmark, is where I'm broadcasting from today. And I really appreciate being able to sort of set the stage for this discussion. And I do have a couple of slides, so let me see if I can upload those. And I believe, can you see the slides? Okay, so I sit in the Vaccine Preventable Disease and Immunization Flagship Program. And the Regional Technical Officer for Disease Control and Elimination. And so I focus mostly on polio eradication efforts, making sure that the region remains polio-free, and the measles and rubella elimination efforts. I think those programs in particular provide a very good example of how WHO provides coordination efforts in the region, as well as provides technical guidance where needed, and has brought together the region to set goals for the region that are in line with goals. And so just to familiarize with the WHO European region, you can see on the map here, we have a cartoon of the region. We have one of the largest WHO regions with 50 states and a population approximately of 1 billion people. The regional office is headquartered in Copenhagen, and you can see that we have approximately 31 country offices, WHO country reps, or other heads of country providing sort of direct country support. And so I thought I would start with what we're currently looking at, which is the European Vaccine Action Plan, which was from 2015 to 2020. And since we're in 2021, we're using this as the opportunity to evaluate how well we've done with this vaccine action plan that was agreed to in the regional committee meeting in 2014, and provide some guidance on specific disease control goals. And so this slide is from the midterm review, which was conducted in 2018, and outlines the polio-free status, which thankfully was on track, the elimination of measles and rubella, which at that point had not been achieved, and the control of hepatitis B, which is still currently in the validation process. And once the evaluation is done to sort of look at the end of 2020, we'll be able to sort of provide more feedback. So I'll focus on the polio and rubella in particular in this presentation. So as we come to the end of this particular European Vaccine Action Plan, we have the next iteration of sort of the global program, which is the Immunization Agenda 2030, which is a strategic plan. And so we are currently here at the regional office in the process of coming up with the EIA 2030, which is the European Immunization Agenda 2030. And so we are looking at how we're going to be able to incorporate those elimination and eradication goals that are appropriate for the European region. So I'll start with polio. And here is the polio-free status for 2019. Many of you probably know, there is an independent group of experts called the Regional Certification Commission for Polio Eradication. They meet on an annual basis, and the last time they met was in September of 2020 to review the 2019 data. And based on the reports that are submitted by member states, we were able to confirm remain polio-free and that there were no polio-infected countries for 2019. So this is in line with the work that the region is doing, that member states are doing in order to ensure that we remain a polio-free region until the global program can declare the world polio-free. We have a couple of countries in the Eastern Mediterranean region, particularly in Afghanistan and Pakistan, that are still have wild virus circulating. And so I think a lot of efforts are being made to ensure that that program moves ahead and that those countries can achieve the polio-free status. So along with reviewing the polio-free status, the Regional Certification Commission also evaluates risk. And so they look at a lot of things, including immunization coverage, surveillance of polioviruses. And so they come up with this risk map. And so what it does is it highlights those countries that may be in danger of circulation after importation or the emergence of a vaccine-derived poliovirus. And so the commission ranks the countries from low risk to intermediate risk to high risk. And it's a variety of factors that go into this calculation, but it helps us to sort of evaluate where us at the regional office need to provide additional technical assistance or to provide different guidance on how to implement certain programs to mitigate risk. I will highlight that since the Commission met in September of 2020, we have had an importation into Tajikistan from Afghanistan with a virus that has origins in Pakistan. It's a vaccine-derived poliovirus, which is not the same as a wild poliovirus, but still requires interventions and activities. And so currently we're providing support to Tajikistan along with the global partnerships for polio eradication to conduct campaigns in May and June to make sure that we respond to this appropriately and that we protected the rest of the region. And Tajikistan has done a fantastic job in preparing for this campaign with the new and improved oral polio vaccines. And so I think this is something to highlight that, that despite the region being polio-free, that we are at danger of importations from our neighbors at any time. And so continuing those efforts for high vaccination coverage and good surveillance are quite important. So to give a little snapshot of the verification of measles and rubella elimination, you can see here that the region as a whole, all 53 member states taken in consideration, have very high coverage for the first and second dose of measles and rubella containing vaccine. And we're one of the only regions in which every country has an immunization schedule that includes both measles and rubella, and all countries in the region are using measles, mumps, and rubella, or measles, mumps, rubella, and varicella combination. Provides a real great coverage for the region. I mean, despite that high coverage, you can see that in 2019, we had a lot of measles cases in the region. And I think it just highlights the issues that we have with some of the subnational coverage or pockets of unimmunized children and adults. And so there were a lot of efforts to combat that through supplementary immunization activities and to sort of react to those measles cases. And so I think this is really great, a great opportunity for us as we move into 2021 to hit where those gaps are and try to respond to them. So like polio, we have a verification commission that looks at the measles and rubella status of the region, and were created in 2011 and have been evaluating the status of the region since 2012. They met for the last time in December to review the December of 2020 to review the 2019 data. And so here's a graphic showing the number of countries that have been eliminated or that have been able to interrupt. And you can see that in 2019, because of those large outbreaks that were in 2018 and 2019, that we've had a couple of countries that reestablished transmission and were unable to sort of stop those large outbreaks before the evaluation of the commission. And you can also see that we did in 2019 have countries that were unable to submit documentation in 2020, and that was mostly because of the coronavirus outbreaks. Many of the programs, the people that are doing measles and rubella, were also tasked to work on coronavirus response and now vaccination. So we're hoping that when we evaluate the 2020, that we will be able to sort of review those countries that were unable to submit and complete this graphic. If we look at rubella, you can see that there's been tremendous progress in the region. And I think that we are extremely close to being able to verify the status of rubella being eliminated in the entire region. We have a couple of countries that didn't submit because of coronavirus, And then we have a couple of countries that we've initiated a new program, particularly for rubella, to make sure that it gets the much needed review with some retrospective reviews of countries and to make sure that the data reflects the actual situation in the countries. And so I'm fairly confident that we do not have ongoing widespread transmission of rubella in the region. And so we're just working very hard to make sure that documentation is complete and we can submit to the Commission for them to review. So I'm quite hopeful that this year we'll be able to complete the verification of rubella. And so that would be a great accomplishment for the efforts of the member states, and it would be the second WHO region after the Americas to verify the region as being rubella eliminated. And so I think that would be something quite tremendous for us to be able to document and then to obviously celebrate. So, looking at WHO, and particularly in the European region, one of the big, I think, advantages that WHO has is that it provides an opportunity to convene member states. So WHO has this convening power to bring together the members of the region. And in previous regional committees, the member states have been committed to maintaining the region's polio-free status, and then also several times to working to achieve measles and rubella elimination, and then controlling hepatitis B. And so based on that commitment from member states, here at the regional office, we really are committed to coordinating and supporting technical support to achieve those goals, and looking at how we can do that at the national levels or sub-regional levels by grouping together countries with common interests. We have in the past, particularly the polio program, used sort of Central Asia and the Caucasus as a block of countries to coordinate campaigns within the European region, and then also with our neighbors to the south in the Eastern Mediterranean region. And then we've also are able to mobilize global and regional partners, different mechanisms. And then, of course, here at the regional office, we support those independent advisory groups and commissions to provide guidance through the European Technical Advisory Group or through the Polio Regional Certification Commission and the Measles and Rubella Verification Commissions. And so that's just a very short snapshot of where the region is as far as polio, measles, and rubella, and then also some of the sort of support that we provide and guidance that we're able to provide here from the regional office. So I really appreciate this opportunity. I wish I was able to join you in person, but I'm happy that I was able to connect via this forum. So thank you very much.
Thank you very much, Patrick O'Connor. We have achieved a lot in terms of polio status and measles and rubella combating. We will prevent hepatitis B, but as you have mentioned, we should keep track on it, and we will keep track on it in order to confirm the elimination of measles, rubella, and polio. Thank you very much for your presentation. Our following presentation is adequate epidemiological surveillance over measles and rubella. Olga Tsirkon, the head of the epidemiological department of Moscow Scientific Institution of Epidemiology, of Rospotrebnadzor of the Russian Federation. Olga, the floor is yours. Good afternoon, dear colleagues. Let me express my gratitude to the organizers of this conference for the chance to present the results. It is common knowledge that the system of managing the epidemiological process includes epidemiological surveillance, and its role is crucial. Organization, flexibility, and timely response and fullness of epidemiological surveillance determines the substantiated decisions of management, and also epidemiological surveillance determines the effective activities. The key goal of epidemiological surveillance is to minimize the uncertainties while making the decisions. It is achievable by organizing monitoring of morbidity, monitoring of circulation of the pathogens, and monitoring of population immunity. This regimen is widespread for all the infections. It is applicable for epidemiological surveillance. In 2002, the European Regional Bureau of the WHO set the goal of elimination of measles and rubella by 2010. The RF devised its own program aimed at elimination of the measles infection. This regimen of epidemiological surveillance was not satisfactory, and we had to arrange epidemiological surveillance based on integration and laboratory confirmation, and accounting for all the cases which are suspected cases of measles. In 2002-2003, we organized national scientific and epidemiological centers for measles surveillance. There were also 10 regional centers. The laboratory network for verification of each case was created. Monitoring of molecular and genical typing of circulating strains of measles was organized. We also launched individual accountability of morbidity. For this reason, we devised additional report forms on a monthly basis for each age group and history of vaccination. And there was also the report for epidemiological investigation for suspected cases of measles. These documents played the key role in understanding of changes in the epidemiological process of measles. Individual accountability of morbidity is not that new for us. It was first introduced at the federal level, because at the second administrative level, at the level of district sanitary and epidemiological stations, these reports were used for individual accountability, but it was limited by this scale. We also had to review the legal framework, which was obsolete. They were dated by 1987. In 2002, we introduced methodological guidelines, where we first indicated that adults aged 23 to 25 years old was considered as the study group, and the criteria of well-being was 10 to 30% of serum-negative people. For epidemiological monitoring, the ELISA method is recommended. This reaction was substituted by ELISA because it is more elaborated and more state-of-the-art. The legal framework has the following indicator age groups for for serum monitoring. They were modified, and the last happened in 2011. These changes corresponded to the changes in epidemiological process of measles. comprehensive analysis of morbidity based on the epidemiological reports and monthly reports allowed us to document the shift in morbidity. And there were more people who were adults, aged 18 to 35, and they were not immunized, they were not vaccinated, which resulted in the activities we undertook in 2004, 2006. We conducted immunization in people aged 18 to 35 who were not vaccinated. Since 2007, this age group has been included in the national schedule of vaccination. The people who were not vaccinated and who did not have a history of measles were vaccinated. We followed the two-dose strategy of immunization, which is very effective according to the global experience. Also, in 2007, we launched vaccination on epidemiological parameters or measles for adults without any age limitations. All these events allowed us to significantly increase the population immunity with the vaccinated people. Individual consideration of cases expanded our opportunities in terms of understanding the crux of the changes taking place in the epidemiological process. We managed to characterize each case and to carry out epidemiological research, which allowed us to set the chains of transmission. And this secondary transmission was truly time-consuming in the territory. And it also indirectly provided to us with the information of the condition of the population immunity. At a certain territory of our country, we assessed the places where focus occurred and also the professional structure profile of the infected people. Since 2012, we have introduced the individual consideration of rubella cases. The integration of surveillance over rubella took place in the existing system of epidemiological survey over measles. It's for good, but this individual consideration set new goals for us, and it conditions the need of inclusion of the specialized computer software, which would allow us to process a lot of data. I do not only mean the confirmed cases of measles and rubella, but also the cancelled cases. This program was devised in 2006. Then it was elaborated in 2019. We could see the final version, and now it is represented on this slide. Also, this program enables us to form the reports for the WHO offices. The parameters of selecting the information for analysis look this way. And this list was also elaborated. We added new components in it. One of them is epidemiological classification of the cases. The WHO put forth this classification, the local cases or the displaced cases from the territory, and we were not satisfied with it, and we added new cases in this classification. We added the cases which were imported from other territories but within the country. This classification is a little bit simplified, but it did not reflect the real cases and the real processes. They are well represented in the territories which were supervised by Rostov Regional Center. In 2014, we registered imported cases of measles. You can see the red arrows. The arrows represent the cases. And they were also substantiated by local displacement and migration of the population. You can see the black arrows. And women, the gypsy population. Thanks to this information, we paid special attention to the changes in the social and professional profile of the patients, which signify the priority. We started monitoring the vaccination in hard-to-reach groups of the population, such as members of religious communities, compelled migrants, displaced migrants, the gypsy population, which is not covered by the system of healthcare, and migrants. We developed and put forth the indicators of quality of epidemiological surveillance for verification. One of them is the indicator of excluded cases. There are at least 2 of them for 100,000 people. Nowadays, 2 kinds of surveillance function successfully in the RF. There we can see the routine surveillance with specific diseases such as measles and rubella with typical symptoms and signs. And there is also active surveillance in place based on the syndrome. Active surveillance was introduced in 2007, and its quantitative parameter 2 per 100,000 people was elaborated in the course of the pilot project in 2005-2006. This enables us to assess the cancelled cases thanks to 2 kinds of surveillance. Our indicators exceeded the criteria on an annual basis in our country. I mean, the criteria of quality and epidemiological surveillance. We maintained the sensitivity of epidemiological surveillance by tactics of laboratory examination. All the negative serums were titered for IgM antibodies to measles virus, and the negative cases for measles were titered for rubella. Back in 2020, we faced some challenges due to the COVID-19 pandemic. Still, we managed to retain this parameter of sensitivity of the epidemiological surveillance. We could not register the morbidity since June. Thus, the examination of the patients with these diseases still took place, and we accentuated administrative resources. I mean, active surveillance. The patients were examined, and even the patients who suffered from COVID-19 were examined. We did not detect any positive measles cases in this category of patients. The analysis of imported cases showed the clear trend to prevalence cases of importation from the countries of former USSR republics. It's over 50% regardless of the absolute figures. their numbers hesitated from 27 to 132 cases. Still, you can see the proportions. And they were always over 50%. The results of molecular and genetical typization allowed us to identify the genotypes and subtypes of measles virus, which circulated in a short-term period in our country, and we had never faced them before. This allowed us to think that the infection had been imported. Epidemiological situation always had some leaders among the countries. In 2019, most cases were imported from Ukraine, where the measles outbreak was registered, but in 2020, the priorities changed, and most imported cases took place in Uzbekistan. In the epidemiological period of 2019-2020, the outbreak was registered. Thus, to sum up, let me mention that Russia has effective epidemiological surveillance over measles and rubella. It allows us to get comprehensive information on time. We have borders with 18 countries. We have intensive economic, trade, and cultural links. This substantiates the dependence of the epidemiological situation in our country on epidemiological well-being. In terms of measles and rubella in neighboring countries, the predominance of imported cases in former USSR republics confirms the presence of this dependence. The detection of the genetic alliance of the strains of measles, which we have never faced before, allows us to think that we have missed some cases of imported infections. Another far-reaching goal of elaboration of epidemiological survey over infections at the stage of elimination is systemic interaction between the services of sanitary and epidemiological well-being of member states of the CIS for make people be informed of measles outbreak and it is also used for preventing the infections. And thank you, Olga.
You had a very good presentation. Thank you. That your R&D institution is contributing much into the list of Eurosec and Sanitary Epidemiological Service research, and indeed the retrospective programs to be studied make it possible to have the proper epidemiological decisions. Measles identifies itself pretty often. It is some kind of an imported infection, but always we have to be in the state of alert. Olga Ivanova, the senior fellow at the Chumakov's Federal R&D Center, and she's going to develop on the contribution of the Russian Federation for maintaining polio-free status of the European region. Alexander, thank you so much. I cannot download my presentation, and I cannot use the clicker properly. Okay. Dear colleagues, Poliomyelitis is one of the most ancient infectious diseases, and it entails the paralytic status, a very social, very tragic social phenomenon, and it is a very heavy social load for the society at large. And the high epidemiological situation for that disease has been witnessed on the threshold of 19th and 20th century, and therefore it has become an impetus for the R&D regarding the vaccines and also using the poliovirus vaccine, and those achievements allowed in 1988 to declare the global initiative on the eradication of poliomyelitis. Yeah, that's it. Thank you. Thank you for your help. At this point of time, some prerequisites were formed in order to activate the program for combating polio and eradication of other diseases. And already we had some indicator for technical capabilities to eradicate polio. And in 120 countries of the world, we had 350 cases of polio initiated by the wild poliovirus. And we have to be based on the state-of-the-art concept for eradication of this disease. And nowadays, we have the strategic program of that sort, the vaccination for 95% of children, and also surveillance over the paralytic status and the treatment. And so we have been involved in the examination of the acute and moderate diseases, and we had 123 accredited labs, regional reference labs 16, specialized reference laboratory 7, and actually all tests are being conducted with regard to polio. What is the situation with the elimination of polio in the newly independent states from 91 to 95? And the majority of cases related to the wild polio virus had been registered at the domain of the newly independent states, or CIS countries. And the Russian Federation had the outburst of polio in Chechnya and in Ingushetia, encompassing 146 cases. The Russian Federation has a national program for elimination of poliomyelitis, and it was done at the level of epidemiologists, clinicists, virusologists, and the managers of the healthcare system. And this program is based on the various pillars. That is the methodological legal regulatory framework, international cooperation as of 2006, and we are a part of the global initiative for the eradication of poliomyelitis, and also the lab network, which was set up at the level of the Russian Federation, encompassing 6 subnational, 7 national labs, and on the basis of the national lab in the center of Chimakov, we have the regional one, specifically for poliomyelitis. And with due regard to the implementation of the action plan, the indicators for planned immunization were presented at a higher level, and also the surveillance procedure was deployed, and wild polioviruses were not detected further. And the Russian Federation, as well as other countries of the Central Asia and Mediterranean, took part in the unprecedented operation named Mekacar and Mekacar Plus. And the cornerstone idea of this operation is to synchronize the vaccination campaigns in 18 countries and territories of the Mediterranean and the European part. More than 105 million children were vaccinated, and as a result, by the 21st of June 2002, the European region was registered by WHO as a polio-free region. And what are those follow-up periods for the polio free status maintenance? And it has to be done upon the certification. And within a certain period of time, the immunization is maintained at a very high level, high indication of surveillance level, is in tune with the recommendations of WHO. Also, we provide the survey, the research of the effluent waters, and also we examine the displaced persons and migrants. And in 2008, the national calendar has 2 doses of this virus vaccine embedded, and we started using the bivalent oral medication. And the Chumakov's Center has regional labs as well under the auspices of WHO, and such cooperation contributes a lot onto the high level of sustainability of this polio-free status. And as of 2003, the regional reference laboratories surveyed the materials from more than 6,000 cases of paralytic outcomes, and that was fully we were fully in charge of this survey, and quite a number of supplementary materials were collected within the framework of this surveillance idea politics, and some were self-isolated as a result of such examination. The program of eradication of poliomyelitis is a very long-term one, and under the auspices of WHO. And in the course of its implementation and following some complications, we've managed to achieve quite marked success. And in 5 regions out of 6, we have been witnessing the complete eradication of polio virus of the wild nature. And that activity has been certified. And the global program has come across some certain complications, and that is the polio viral vaccine and strain of the disease. And at the global level, the type 2 poliovirus has become a problem. And upon the recommendation of the Committee on the Sanitary and Hygienic Rules, just announced that some emergency situation may occur relatively to the polio virus. And as you see in here, over the past few years, probably starting from 2016, this polioviruses started to disseminate it all over the African continent. And we witness also here the combined polioviruses dissemination in Pakistan. What kind of risks we are looming large over? And for these countries, we do remember the outbreak of poliomyelitis in Tajikistan in 2010, and poliovirus number 1 was imported to adjacent countries from India, and more than 460 cases of the paralytic poliomyelitis were identified. And actually, we have vaccine-associated polio and also poliovirus of the vaccine origination. And we discussed it at our sessions, and Tajikistan already come across the problem of two-type poliovirus, which comes from the Afghan and Pakistan cluster. And this virus was detected as a result of the acute and moderate cases, and COVID-19 pandemic resulted onto the vaccination scale of poliomyelitis. So immunization is the #1 measure. The broad-based coverage is another measure. Safe vaccination, just reaching the remotely located groups, also the efficient vaccination, and the key goal is to have a high level of the collective immunity, and also accessibility of vaccination while ensuring a high level of vaccines, and also epidemiological surveillance over the paralytic outcomes, but also we need to enhance some supplementary types of surveillance, as well as HIV-infected persons. There should be some containment for storaging the poliovirus. Also, we have to go on the R&D on the polio, and also I haven't come across the origination of the new monovalent vaccine of the second type, and it could be safely administered to curtail the outbreak of polio. And also we have to oppose the anti-vaccine propaganda. And I would like to thank all the followers of this program and all the staff of the Chumakov Center, Rospotrebnadzor, the Federal Center, and the Center for Epidemiology, and the staff of this Moscow State University named after Lomonosov, subnational laboratories on poliomyelitis of the Russian Federation, newly independent states, WHO HQ, WHO Euro, and all the colleagues from the global network for poliomyelitis labs. And indeed, the organizers of this Congress allowed us to get together here, exchange data and exchange views vis-a-vis the epidemiological well-being at the level of our countries. Thank you for your kind attention.
Thank you, Olga. At the end of the session, you have the Q&A, and now we have a chance to make an exception because we'll have the dinner right after the session. There's one question for you about your presentation, Olga. On behalf of our country and the Ministry of Health of the RF of Kyrgyzstan, let me express my gratitude to your team, to your institution, and to you, because your work should be appreciated. We are not satisfied with the situation in the neighboring countries. We have already declared it the territory of Tajikistan. We can see the emergency situation. We launched the campaign aimed at administration of inactivated polio vaccine, the population has a negative attitude to the fact that the authorization of this vaccine-associated strains takes place. We cannot tell the mothers and the population of the country that there is the reason why it is actually authorized. And we can also see Patrick, the WHO representative. Should we maybe develop the guidelines or the communication in the emergency situation? What is your attitude to it? Will you render some technical assistance in this regard? Thank you for your good words. We have been working with Kyrgyzstan for decades. We are happy to assist you. As for technical assistance, we face the problem of poliovirus, of vaccine-originated poliovirus. Then this problem does not affect our region. We did not pay attention to it, but we created the methodological basis in the region. We have special documents on risk assessments and on laboratory examinations. If you need some assistance, don't hesitate to address us or to Rospotrebnadzor. We will provide you with the necessary assistance so that you could be ready to combat this situation. Thank you very much. Thank you. Thank you for your contentful presentation. Polio is the infection which we managed to combat, and we practically eliminated it. Still, if we stop carrying out vaccination, we can see that the situation may be aggravated, and our work could be considered as futile. Thank you very much. Now, let me give the floor to the head of the Republican Center of Immune Prevention, Immunization during COVID-19 in the Republic of Kyrgyzstan, Gulbara Ishinyapsova, who is the director of the Republican Center of Immune Prevention. We've already touched upon the planned immunization, and you all share your working experience in the situation when the epidemiological situation is not favorable. Thank you very much, dear colleagues. Let me thank all the participants, and let me thank our colleagues from the RF. The immunization issues allowed us to discuss it jointly. This issue is really topical. Let me present you some information on COVID-19 and impact on planned immunization in Kyrgyzstan. Let me highlight that the country respects all the global goals aimed at polio elimination and the measles elimination in the European region. We're also guided by the European Action Plan on vaccination. Our 5-year programs were completed successfully. There were 5 programs of immunoprophylaxis. The next slide is the following. We updated the policy and reviewed the priorities of the system of healthcare during COVID-19 pandemic. It was the priority of the healthcare system. In 2020, it had a negative impact and created a risk for immunization program on the whole, because the potential of the WHO and medical personnel providing immunization had to undertake the response measures while combating COVID-19. During the COVID-19 pandemic, since March 23rd until March 26th, we suspended planned routine immunization in order to stabilize the epidemiological situation. related to coronavirus infection. The vaccination of newborn babies in the organizations of delivery care was not interrupted. It was emergency prevention against the measles of contact people, and then it was planned immunization was suspended for 2 months. We undertook strategical planning, and it included special measures of response in the conditions of COVID-19 pandemic, and then the Ministry of Health decided to renew planned immunization and to accelerate it, as well as to provide medical and sanitary services. Currently, immunization still takes place in the organizations of healthcare, which provide immunization services. We use strategies of vaccination sessions in outpatient care, and we also involve mobile units. We use Gavi means while impacting COVID-19. We reprogrammed these means, and then they were sent to the events, to the activities aimed at decreasing the outbreak of morbidity of COVID-19. And we also decided to decrease the negative impact of planned immunization in compliance with the national plan of the international and intersectoral coordination and the readiness to respond to COVID-19. Mobile brigades were involved in this process. First aid kits and PPE were delivered. The UNICEF means were used for equipping the vaccination points. Sorry, can you see the presentation? Thank you. Now we'll touch upon the coverage with preventive vaccination. The monitoring of coverage with preventive vaccination, epidemiological surveillance over vaccine-preventable infections allowed us to conclude the following. In the pandemic, the primary vaccination complex decreased by 13% compared to the results of 2019. Over 21,000 children were not vaccinated. The children aged under 1 year old. And over 22,000 children were not vaccinated against measles. There is also a risk of infection progressions. It may be prevented by vaccine prevention, and outbreaks may occur. The inequality aggravated, gender inequality, and the risk of the condition of the impoverished population also increased. The coverage with the primary vaccination complex can be seen here. The results are presented for 2015-2020. We can see the decline in the results for 2020. We can see the Penta 3 coverage at the subnational level compared to 2019-2020. Here, mapping is represented, as well as the areas which we divided. These areas are the following. 90% account for the red color, and we also have the yellow zones, 90 to 94%. And our indicator implies that our country should reach at least 95% in such regions. And the highest risk occurs in Bishkek, as well as in Chuyska region. It is up to 1 million of the population. And the risk population is related to Penta 3 indicator. You can also see that KPK1 is not in the critical situation because the outbreak of 2018-2019 allowed us to enhance the epidemiological precautions for medical workers. We have completed this work, which is much higher than Penta 3. Epidemiological surveillance and morbidity are represented here. We focus on the impact of COVID-19 on epidemiological surveillance. We did our utmost to respond to the situation with COVID-19, and the lockdown measures decreased the registration of vaccine-preventable infections, and morbidity of perioditis decreased by 11% compared to 2019. Over January-December 2020, 733 measles cases have been registered. Since June 2020, no one has registered measles on all the territories of the Republic. Since week 49, 2020, we have registered these cases in Chelyabinsk and Sugutska regions. We can see the retrospective analysis for 3 years. You can see the outbreak, which occurred at the end of 2017. They were imported from Moscow, from the RF. The strain was genotype. Here we can see the cases till July 2020. We also carried out the outperforming immunization. We used the WHO tools, the guidelines aimed at attenuation of negative impact of COVID-19 on combating the disease. Diseases which are vaccine preventable. There are also guidelines on routine immunization during the COVID-19 in the European region. We also have devised the national plan aimed at immunization in accordance with the WHO guidance. Here you can see the contribution of mobile units to planned immunization. They were used during the outperforming immunization. You can see the proportions. There were 4 rounds or even 6 rounds in 2020, and we received these results in these mobile units. You can see the contribution of the mobile units. Over the whole territory, we have involved for 64 mobile units. There were over 155 cases of vaccination, and 87.6% accounted for children of under 16 in this region, which was involved in the process. And the contribution of the mobile units was observed in Osh and Sokolska region. Now we move on to demand and communication. It is of prime importance nowadays. The demand for immunization services during the COVID-19 pandemic decreased because people did not trust the vaccination because of rumors or incorrect information, and transport communications were also limited during the lockdown. Currently, public communications associated with COVID-19 undermines trust to the system of healthcare, and it also depreciates the vaccine against COVID-19 and questions other vaccines in the framework of our expanded vaccination program. People have doubts on safety, on quality. People dwell upon chipping, and this affects our population. It is of prime importance to raise the awareness of trust in vaccination in our population. We have elaborated our website about vaccination. There were over 400,000 followers, and our university provides technical assistance. It may be included in the list of reliable services on immunization, and now we are working on it. And we also enhance trust. We have been supporting the WHO initiative on the European Week of Immunization. We also organized hotlines on this website so that the population could receive reliable information. Now we move on to vaccine delivery. There was no deficit, there was no shortage of vaccines in the COVID-19 era. It is provided by the UNICEF delivery department. We face some risks. You are aware of the political situation in our country, you're aware of the revolutions and the changes in the government. It negatively affects budgetary funding and co-funding. But let me highlight that we do not have any debt nowadays. Here we can see the mobile session on how to reach population in terms of geographical and social priorities. And this hard to reach population is achieved by us. We also engage the Red Cross volunteers. It is needed for both vaccination and for carrying out questionnaires. It allows us to share the information which is crucial to our population. I changed my presentation a little bit. That is why I was a little bit anxious. Mobile clinics were also involved thanks to the RF efforts. In January, March 2021, we engaged mobile clinics within the project. We were involved in 5 regions. Brurotal is the most active one. We have covered over 3,000 people with these mobile units, and we will keep working on it. All our resources and our expenditure were implemented via the WHO. Here you can see the link to our website. It is available to everyone. It is really interesting. We receive good feedback. Here you can see my grandson and my daughter, and they came to vaccination, and I took a photo, and you can see this photo on the website. I wish you great success. Hopefully we should start everything with prevention. I mean, vaccine prevention. Despite the pandemic, as Anna has already mentioned, we shouldn't forget about other infections which come back, which remind us of themselves. They're even more hazardous than our novel coronavirus. Let me once again express my gratitude to our colleagues from the Institution of Krzyzewski, because your contribution is great. We have been working within this project aimed at elimination in Middle Asia. Hopefully we will be able to keep working on these projects. Our Center of Prevention will fulfill all the obligations. The RF is our key partner. Thank you very much.
Thank you, Gulbara Saktagulovna. Actually, Gulbara was our last speaker, so I suggest to put the questions from the audience, or Olga Valentinovna will put her questions, And within the coming 10 minutes, we may comment, put all sorts of questions further. Thank you very much, Gulmara. Thank you for your very good words addressed to us, and more than 200,000 children were not covered by the vaccination. But you talked about mobile teams, and did you manage to identify non-vaccinated children over 1 year old? That's my first question. And my second question is that you've mentioned the vaccination in the hotspots for missiles. What about the legal regulatory framework? Does it fit into this particular framework, and what is the current status for vaccination? As to mobile teams, I would like to say about their weighty contribution onto the vaccination process, and they used the entire potential of those mobile clinics. And I took into account February, and now we have some kind of catch-up companies, follow-up companies, and that was all organized by our STAT committee. But now, I guess that this percentage will be about 13 originally, but now it's 8% for children. We covered the majority of those originally not covered. And some statistics arrives later, by the end of April. And as to some kind of a follow-up companies, we suggested some urgent vaccination, and we never stopped the vaccination. That was mono vaccine for measles. And nowadays, we use 50,000 altogether, and that was all decided by the regional headquarters. And no longer we have a quarantine. In the Republic, it has been lifted, and the vaccination is fully accessible in the hotspots of diseases. This follow-up vaccination is not characteristic for Kyrgyzstan. It is a problem for all the republics. Thank you, Gulbara Sultagulovna, for sharing expertise of your own. Probably we have other findings to remind and discuss. Any questions in the audience? Maybe someone would like to write from the studio, from the online. By that, we terminate our session and declare the break. And I would like to thank all the panelists of this session dedicated to the controlled infections and vaccination. Thank you for your weighty contribution. I wish you all the best and very successful and fruitful deliberations for the sake of our population and our countries as a whole.
detailed and substantive. They are introduced on an annual basis. You can see the figures on all the regions. Similarly, the program has full-fledged data on the countries where infections occur. We can see the growth in the number of new patients, in contrast to many regions of the world where the epidemic is currently being controlled, but we are aware of our situation. Over the last years, we have decreased the number of new challenges of the new HIV cases. But unfortunately, the situation is totally different in other countries. In ECA, we can see the 275% growth. It is either super epidemic or the false figures. Here we can see the prevalence of the HIV infection in our country. My presentation will then follow, and then you'll listen to Professor Nechaev's figures, who will present the recent data. The situation in Ural in Siberia is sorrowful. As for the situation in the USA, we can see the territories, the urban quarters, which have great differences, drastic differences, which are affected by this disease. Still, these figures in some regions of the USA are tremendous. They're extremely high. And the figures in the ROW also make us fear. We can see two kinds of statistics. The data of the Rospotrebnadzor and the Scientific Epidemiological Center's data. This data is included in the total statistics. We can see the disparity, the large gap. Vasily Kravchenko will dwell upon the figures. They are analyzed in a detailed way. Here you can see the situation in Moscow. We're aware of the number of all the patients. We work with them on an annual basis. How many patients are there in Moscow in total? We identified 1,3,500 patients. Some of them died. Some of them died, and some of them died, but we are not aware of it. They haven't referred to our center for over 7 years. We work with civil registers. Some of them do not report to us. Now we're actively searching for these people. Maybe they are buried in other regions of our country, but in the past we couldn't manage to identify them. The data is transmitted to us, and we can see statistics on the people who died of this infection. It is accurate, and it is related to certain regions. These cases were identified in Moscow. Still, they are still here. Some of them came here from Moscow in order to receive medical care. We're happy that people from all over the country come here in order to be treated. But this doesn't mean that all of them live in Moscow and that Moscow is their place of residence. How many patients are actually here in Moscow? Some of them are under our regular medical checkup. We have medical reports. We can understand how many people are there in Moscow, where their address, their places of residence. Let us review this data once again. In 2019, the data presented in this report have increased 3 to 6 times compared to the real statistics. It's not the only figure which has changed. 6,000 people moved home in order to report for them, and 12 people were added. That is one of the most explicit sources of these data gaps. And we will also dwell upon it. Here we can see the new cases in Russia and the decline in the number of new patients associated with intensive growth of tests for HIV. Our regions have conducted this work. The Ministry of Health of the RF has carried out lots of tests for HIV. We covered lots of regions and created the favorable environment for those who have to be tested for HIV. And now we go further. I hope that we will include the professional community in the HIV programs for checkups. We are also streamlining the economic aspect of this work. We can see the following strategy. The tests for HIV are objective, and we did defend this strategy. Now it is normal for all the countries, and then we'll include the tests in the checkup program. It will be our next step. It's rather substantive. The number of the detected patients has decreased drastically, and there is a link between the number of these patients and this study. We could see some data on the analysis of mass screening for detection of them. We can see lots of indicators and formulas. We know that these high levels of screening allow us not to impact the number of new patients. We detect those who have to be detected this year. We can see the detectability this year. It does not depend on the number of studies. It shows the trends, the declining trends, and it is our key indicator. The number of studies decreases, whereas the number of people diagnosed increased. This confirms our thesis. Still, we haven't carried out the scientific work. We haven't published it in the articles, but now we have this data available and we can show the statistics. The number of studies and the number of tests for HIV has decreased drastically due to the COVID pandemic. It decreased by 50%. The number of the examined people decreased by 50% in all over the world, according to the statistics data of different countries and monitoring centers. The key points are represented on this slide. We have lots of people examined in Europe. And how does this decline impact the situation? Despite the events of this year, the situation has decreased the number of tests for HIV infection in a minimal fashion compared to other countries. Evidently, over 90% of our patients are aware of their status. It is the vital indicator for our country, and it has been fulfilled long ago. Here is the register of the patients with HIV infection. It's important work of the previous strategy, which was implemented in our country in 2011. We decided not to carry out such register for several reasons. It was the political will of those who decided to carry out it, and they did carry out it. It's respectful. It's a unique tool which allows us to work with this data in a comprehensive way. I mean the data on the patients in terms of epidemiology and the needs of the patients who have to be diagnosed and treated. We'll have a particular presentation on this issue. According to the register, we face some challenges. We understand that this database is not like EMIS, where everything is digitized and there is a barcode on each test tube, and then the data is included in the medical records, and everyone may scrutinize it, and everyone may control digitized healthcare. Moscow is an absolute leader in this area, but now this register also gives us such opportunities. We live in an immense country. We are not always satisfied with the data transfer, and not everything can be implemented in our country in the full scale. And we don't have any manual work. Still, this database contributes to statistics this year. The register forms the 61st form. It is the crucial landmark. We have the resources reflecting the statistics of our country. Another chief aspect is coverage. It is questionable. Still, we can see the coverage rates over the last years. The Ministry of Health has conducted great work, as well as the territory centers of combating the HIV infection there are 200,000 patients who are now receiving the ARVT drugs in our country. We are leaders in terms of enhancing the coverage under harsh conditions.
And another thing to mention, and another challenge for our patients, as opposed to Eastern Europe and Western Europe, is that Russia has become the hostage for drug abuse. And HIV is an indicator of this particular problem. And the cohort of diseased are those who were HIV infected upon the drug injection. And the question arises how the treatment needs to be organized, the commitment to that treatment, the regimen for that treatment, and they might not be necessarily HIV infected and also have the C hepatitis. And we in our centers have to cure co-infection. And actually, we are keen on the elimination of hepatitis C, and that is an outstanding program, and it is attainable with due regard to the expertise we have acquired in combating HIV infection. And for a number of years, we've been handling the mass scale diagnostics with the titles of viruses and individual selection of treatment for each patient. And the first here shows the scheme of and recommendations for treatment upon the WHO practices and recommendations of the United States. And the scheme of the first line looks somewhat different as opposed to the current one in Russia. And we have the 5-year system, the based treatment, and that is a full-fledged scheme for the treatment of the first-line patients. And of course, we need some TDF, and if we have some kidneys problems, we have to add some other things. And that is why the scheme is patient-centered, the scheme of treatment, especially when we are on the start. And we have to start from one scheme, then speed up, and then somehow adjust the new scheme of treatment. And already we had some applications arriving with the new procedures and procedures which are individual ones for patients. COVID is an absolute disruptive factor for us, and it affected to a large extent our reality. And now we have to combat the new infection named COVID, and we taught our doctors of various specialities to treat this infection, pneumonia, and render medical aid to very severe cases. And our labs have become the center for medical examination of various patients. And it becomes quite clear that the challenge we are facing is a real disaster for this country. But our centers managed to survive, and the quality of medical assistance rendered to HIV patients is still the same. It's being maintained, and all the drugs are to be prescribed, all the checkups are necessitated, and each region has its own efficient system for HIV patients, and the system of treatment in particular. HIV/AIDS posed immediately a question as how to combine the treatment of the two diseases, whether these patients are conducive to SARS-2, and pretty soon the scientific community formulated the premise as how to deal with that diseased patients, and already this survey was published based on the Madrid cohort data, and they had a broad-based survey at this point of time at the very start of the pandemic. And what is the actual reality for these patients? Let me remind you that our center opened the hotline, and we have the collectors as one of the drug to treat SARS-2. And a year ago, that was one of the most efficient medications for COVID-19, and HIV medication has become in a high demand, and we had a very high load on the center a year ago. And on a parallel basis, we also surveyed the impact of SARS on HIV/AIDS. And accordingly, the last survey demonstrated the full-fledged picture and how those infections are influencing one another, how to treat those infections. We know the gravity of consequences. If the people have low CD, that is 4, and we have some kind of standalone surveys made dedicated to race and to other infections may also influence the process. Quite a substantial database has been have been collected, and we followed very interesting reports of our colleagues at this forum, and I believe that we know what we're talking about today. We had some kind of unexpected articles to be published in some specific journals. Though the internet data has some other facts to expose which are not in line as to what is being discussed at this forum. Probably internet is the one thing, but the specialized journal has its own takeaways with some very authoritative and competent conclusions. Vaccine for HIV. A year ago, we discussed the regimen for SARS vaccine relatively to HIV infected. We have quite a detailed report provided on that score, and absolutely all the vaccines are available for HIV/AIDS, and we may also have a specific calendar for vaccines and vaccination of HIV patients, and which vaccines are preferable now and could be administered in the HIV center. We knew that Sputnik V was an absolutely safe vaccine. That is the most safe model of vaccines, and it gives a chance to our centers to administer those vaccines quite successfully. And the only detail to mention that if the patient has a CD lower than 200, they have to be somewhat cautious to vaccine. Our colleagues in the Chumakov's Institute have another type of vaccine, and we have the Moderna and Pfizer data, and we also have other data. Thus, we may on the vaccine, and we may insistently recommend to our patients to get vaccinated upon the consultancy with the doctor, and this is a real cornerstone stage of our interaction with the patients. And you would look through the algorithms of vaccination of adults and those other HIV infected, and if it is necessary, some new session would be organized on that score. What is the public strategy for 2030, the government strategy? And it has become a definitive step forward for responding onto the infection. And we are now building up the R&D block, and we have some indicators embedded into that strategy, and they are going to be implemented further. And the minimization of the new HIV cases, full-fledged assistance, medical assistance, and other strategies are embedded here, and we are really keen on the R&D solutions at the global level, at the level of partnerships. And now we have some temporary plans for the implementation of the current strategy, and they look quite serious. And in each region, we have plans of actions with regard to the dissemination of infection, and international cooperation in that area becomes a predominating factor. And I've mentioned already that SARS-2 opened up a new epoch for people focused on viruses. And one of our colleagues, Mr. Liedermann, published a very interesting analysis for various strains on HIV. And we were one of the first to start using these new findings based and we do it on the basis of our hospitals. And our French colleagues published a preprint for 50 patients. At this point of time, we already had 200 patients of that sort, and we also had placebo. And we rendered substantial assistance to our patients, and we've managed to publish the article in various journals in a short period of time. And so this article saw the light, and this international expertise of ours has become indispensable, and we started monitoring the process, and at the global level discuss the new strategy for treatment. And sorry for tautology, we're talking about the new infections. So today we nowadays have the International Expert Council for National Virological Association, and originally it was the partner of the network, and these or that reports of our colleagues were dedicated to these to the issues of viruses. And Robert Gum was the one to be the head of these particular meetings. And we had a chance to communicate with our partners from Japan and other countries. And now we are facing some new challenges, such as SARS-CoV-2, and we understand that such alliances should be open and transparent, and thus we discussed some joint projects and joint findings. And vaccine generation on HIV infection was a focal point. And 7 years ago, when our colleagues came here to Moscow, and one of my colleagues came here. He was at the head of the global program for the HIV vaccine in Bill Gates' office. And we discussed it all together with the journalists, and we spoke about the efficient vaccine to be originated. And we had a hope that President Clinton will see the light and will see the vaccine to originate. He was the one to put the first brick in the foundation of the building for HIV vaccine. And we do quite a lot of work and with contributions, and actually the vaccine will be tested on the third phase. And Anthony Fau is the one whom we've been negotiating on that score. There are quite a number of other vaccines which are being developed, and they're being tested. And I do hope that such breakthrough will soon be visible. And already we have very good developments for cancer diseased people using this targeted configurations. And already we see that the Russian vaccine needs to be created. And this is a part of our new strategy.
Oh. Yes, I exceeded the time limit. Thank you very much. And now let us move on to the following presentation of our session. Let me introduce Olga Nechaeva, head of the Federal Center for Monitoring Combating Tuberculosis in the Russian Federation. The professor, we will keep discussing the topical statistical issues. That's not the name of the presentation, but we will actually dwell upon it. Okay, thank you. Dear colleagues, let me say a few words about the indicator calculations. This year we amended them, and the 61 first form was represented by different departments, and then they will be united by Rosstat, and we will get the total parameters for the RF. We can have the same, these following factors, and we have complete factors, and not all of them are related to the number of patients diagnosed. As for the calculation of the parameters, in accordance with the federal legislation, they are calculated by Form 61, including prevalence and morbidity. As for mortality, it is the Rosstat data. This indicator is aggregated. It encompasses the whole system of healthcare. As for mortality, I've represented preliminary data. It's not based on calculation. We can see the data of Rosstat over 2019-2020. I calculate these parameters for each pathology, including tuberculosis, and the difference in them is at least 1/10, or the difference is insignificant, and the data is actual. What has actually happened? Last year, we organized a similar conference, and I said that the stabilization in the HIV infection is being observed nowadays. It has been happening for 3 to 4 years. This year, the decline in morbidity and mortality is drastic. And this is not only related to HIV infection, but also to tuberculosis and other infectious diseases. And the reasons for this decline is the absence of contacts. The ones who were in the risk group in morbidity and mortality were at home. The contacts were limited over more than 6 months of the year. There are some countries which were highly affected in by HIV, but the foreigners from these countries didn't arrive here. Thus, there was no propagation of HIV infection. And the third reason is the decline in the tests for HIV antibodies. It reduced by 25%. It is the highest indicator in the world. Maybe it was believed that we had not diagnosed some data, but still there is some professional there's a professional examination for HIV infection. When people come to a new workplace, they are tested for HIV by fluorography of thorax, and the antibodies for HIV may also be diagnosed, and some of them are referred to inpatient departments, or some people came to a new workplace and they wanted to be employed, but we cannot claim that we have underestimated the number of these cases. We can see the decline in both morbidity and mortality, and the rate is identical, which testifies to the decrease in these indicators. As for the gender, the rate is similar, namely the decline in morbidity in both men and women. Over the last years, we've registered the dramatic decrease in the morbidity of children. It has declined by 2.5 times over a few years. Today, we register stabilization of HIV infection parameters. We're not aware of the future situation in the post-COVID era. The ones who were not diagnosed last year will be diagnosed this year. There are so many stages when people are tested for HIV antibodies. There is no data on gender mortality for 2020, but I believe that this difference will be insignificant compared to 2019. The core age for morbidity is 29 years old, but in the past, this age was 25, 34 years old, and this year and last year, the peak was 35, 44 years old among women. As for men, you can see the same peak, 45 to 54 years. As for morbidity, mortality, 25 to 34, 50, 55, 35, 44, and we can also see the peak for 35, 44. Who are our patients? Here is the structure of the morbidity. 90% counts for our patients of the healthcare system. In the red, you can see the red color, which signifies the prisons. Last year, we saw the decline in the professional examination coverage. 90% of the patients diagnosed in prisons were diagnosed in prisons for the first 3 days. Nowadays, we have to work on the groups of the social risks, which are known nowadays. Still, we do not carry out sufficient work with them. Who can suffer from these diseases? It's open secret that Ural, Siberia, Northwestern, and some other regions are affected by it, and the gap is dramatic. It is at least 2.5 times. We can see the territories of the first decade of the years 2000, and people suffered from drug addiction. I come from Yekaterinburg, and I observed the situation when the police also dealt with drugs. And then I moved to Moscow, and I saw that the central television showed the ones who were diagnosed. Siberia and Ural were affected by this disease. There are lots of infected patients in these regions. Some of them haven't still been diagnosed, and some of them will be diagnosed in the near future. The women gave birth to babies in 2020, represented here. And many of them were tested for HIV infection. And this indicator is unparalleled of the world, but as for our country, it is included in the standards. As far as I know, few women are tested for HIV infection because it depends on their willingness. If they are in the labor houses without being tested, they will be tested to anti-HIV antibodies. 0.7% of these women are seropositive. You can see the great gap between Ural Siberia, Privolzhia, and northwestern regions. These women demonstrate positive results for HIV antibodies over the last 4 years. 0.9% of all the babies who were born in Russia were delivered by HIV-infected women. That's the most substantive problem we face right now. All the delivery clinics are focused on HIV antibodies according to our standards. Pregnant women are tested for HIV many times, and then these tests are carried out in the labor hospitals as well. And we also focus on chemo prevention, and the level of chemo prevention is not that high. As for pregnant women, we can see those who interrupted the pregnancy, made the abortion, and there is also 98%. I cannot say that the prevention scheme is satisfactory, and some indicators emerged this year. We can now calculate the prenatal risk of infection. It was first registered in Form 21. We can now register which way the patient was infected. We can now calculate the number of confirmations of HIV infection in babies who were born over the first 2 months. I cannot understand any other way of these children. They were not diagnosed properly. Over 2 months, those who are diagnosed with HIV infection, 2/3 are diagnosed on the second or the third month. In some cases, they were diagnosed in 30–40% of cases. They all comply with standards. They have the necessary equipment. They know how they have to deal with these children. Why do they actually diagnose them so late? Some women may leave the labor houses without being examined. Thus, children may suffer from it. And the experts have to dwell upon this work. I've represented the data on all the territories. Hope that Mr. Mazes will understand in which territories the HIV infection is diagnosed too late in children. The lower chart reflects the situation in the territories, and the key pathways are the sexual pathway, the parenteral way, and less than a third accounts for the parenteral pathway. And so the contingency, we can see all the territories apart from the northwestern regions. This late diagnosis has few reasons. Some people diagnose the patients with HIV who were infected in a parental way too late, we have to assess the situation in the northwestern region in order to understand why they are diagnosed so late. The sexual pathway is the major one, and we understand that the most widespread one is parental one. And the ones who were infected in the parental way may now transmit this disease in the sexual pathway. Thus, we need joint efforts in order to combat this infection. Another problem is tuberculosis. One of the key causes of death of HIV infection is tuberculosis. We're aware of it. But over the last years, the proportion in tuberculosis is decreasing because we are cautious about chemo prevention. It has been introduced since 2014. Now we understand that we do need chemo prevention, and this resulted in morbidity. The morbidity of HIV-infected people started diminishing in 2016 when people started carrying out chemo prevention of tuberculosis. Nowadays, we have a lot of HIV-infected patients. I've divided the whole population into the infected people and the people who are not infected. We understand that the morbidity of the HIV-infected people is 60 times higher. I mean, those who have fewer than 200 cells, and in this case, the indicators would be 150 times higher. Some of the works were related to asymptomatic cases. The number has increased almost 60 times. If we hadn't had the HIV infection, the morbidity would have been 21, and the best indicator of the Soviet era was 34, when the HIV infection did not exist. The prevalence and morbidity are normally affected by HIV infection. They are primarily affected by HIV infection. Currently, look, the HIV is decreasing now. In the past, I dwelled upon the stabilization, and now we can see the number of these patients, and our medical care resulted in the situation in a positive way. We should not only combat tuberculosis, but we also need different medical services and social services. What are the reasons for that? We know that the combination of tuberculosis and HIV infection is common in the regions where HIV prevails, such as Ural, Siberia, Privolzhia, and the northwestern region. This regions have the high rates of mortality. In the cases when people die of HIV infection, and more people die of the combination of HIV infection and tuberculosis than of tuberculosis. There are much more patients suffering from tuberculosis in Siberia and Ural. And HIV infection is considered to be the key mortality reason. The HIV infection is the major risk factor on tuberculosis progression. On the other hand, if the HIV-infected people could not suffer from tuberculosis, they wouldn't die of tuberculosis. And the situation with HIV infected people depends on the situation of tuberculosis morbidity in the region. As for the leading regions, the morbidity of HIV-infected people is much higher than the mortality in the central region and in the northwestern regions. It is approximately 2% of the population in these regions, but it is a little bit much higher than 0.5% in the central region. On the one hand, the HIV infection impacts tuberculosis, the morbidity and the prevalence. On the other hand, the tuberculosis impacts the mortality of HIV infection. And we may leave this vicious circle thanks to joint efforts. There are some slides on this strategy. This strategy will be added by the plan of events, of the plan of activities, and it will accurately stipulate our future steps. These criteria differ from the criteria set by the previous strategy. Here, unparalleled. Today, I focused on indicators. Here are the targets of the governmental strategy till 2030. Here you can see the number of new cases. In contrast to anti-tuberculosis services, the AIDS centers were not responsible for epidemiological indicators. They did not discuss either morbidity or mortality, and now these AIDS centers are responsible for mortality and morbidity, like physiatrists who are responsible for morbidity and mortality. The medical examination rates will also augment. For this reason, we'll have to amend the legal framework, and we'll also focus on the transmission of HIV infection from mothers to children. Nowadays, apart from this strategy, we have the ruling 199, and we carry out monitoring within this ruling. On the 1st of September 2021, the new sanitary rules aimed at prevention of AIDS and hepatitis will come into effect. Over the first 15 minutes, the president dwelt upon healthcare. So he mentioned the COVID-19, and then he said that our cardiovascular diseases will be the focus of our attention, as well as the situation with cancer. And he also said that we have to focus on hepatitis C. Nowadays, there will be some changes in our structure. Thank you for your attention.
Thank you so much. After my long presentation, I didn't give the floor to our audience for Q&A. Yes, I talked in much detail, and maybe we have some questions from the audience, because further on I would like to organize the general discussion. Dear colleagues, the floor is yours, and you may put any kind of question to myself and to our second speaker. Thank you. Thank you so much for your weighty contribution, that you came here, found some time, and I would like to send my best regards from Khabarovsk. Thank you once again. Vasily Ivanovich Harchenko, the head of the Epidemiological Clinic and Epidemiological Center for AIDS, is going to talk about statistics. Vasily Ivanovich is ready, and they are in our office. They're located in our office in Moscow, and they, on a permanent basis, used to stay there and communicate with different countries. And we were supposed to organize some kind of a hub. It needs to be organized in a proper way, and we have to tune in. And we had some kind of a hub in the Far East, in the Urals, and in order to communicate with the USA, with China. And it was hard to do with it was very hard to communicate sometimes with Moscow. So Vasily Ivanovich, thank you, Alexei Israelevich. All the activities opposing HIV infection based on the ruling of number 21 for the city of Moscow. We do not see your presentation, dear colleagues. Will you please download the presentation? Dear colleagues, your presentation is not visible. The presentation is on. You have to put it on the screen for the demonstration. We cannot see you. Push F5, yes, to make a full screen. There will be a full screen. It's not a full screen. Please click the demonstration. We have to find the active window for presentation, F5 or demonstration. That's it. Vasily Ivanovich, are you with us? Vasily Ivanovich, please. Now we have a sound. Okay, so the capital of Russia has quite a number of peculiarities affecting the epidemiological process. And really, we have to actually affect this particular situation. We have quite diversified population, and the number of groups of marginal nature and deviational behavior. Again, a problem. And the HIV infection for megapolis is rooted into the pendulum-based type of migration and employment. Therefore, we have the augmentation of HIV infected in Moscow. Labs and the system of lab diagnostics seems to be a predominating one. They're of different organizational style and type of ownership. And so we have screening lab, we have reference diagnostics lab, and also we have some commercial labs. The biomaterials and there may be taken in other regions. And further on in Moscow, it is being screened. And also we have some factors for the objectiveness of the epidemiological processes. And the commercial laboratory or regional laboratory may present not a verified list of surveyed persons, individuals, and foreign-based employees, and sometimes the address is not correct, and sometimes the forms are not the forms which were taken are not very proper, and the terminology implied could be different, and forms and templates could be different. At least 4 of them were valid, and that is why we have some errors committed in the city of Moscow, and sometimes statistics becomes not very verified, and thus people may manipulate this data. And the distortion of statistics are vividly seen in the form number 4. And it was enacted last year, and they changed completely the structure of this template. Well, inserted some new indicators. The table was also inserted, and the groups look somewhat different. And up to June 2020, medical labs didn't work with this form, but Rospotrebnadzor insisted on including this data into the standard template, and therefore public statistics data are distorted due to that fact. And the scenario for duplicating the data on HIV infection is another challenge. And thus, Dni Epidemiological of Rospotrebnadzor could be also wrong, and we have some digital data upon the form 4, but personal data could not be provided from the form 0510 of the Moscow Center for AIDS. It looks somewhat different, and they presented statistics for the region, and initially it is not visible who the people are and where do they come from, thus entailing the duplication of this data and just shaping up just in the wrong profile for the statistics in the region. We try to optimize the entire process for HIV testing, and we stimulate the population for testing, and we have to organize testing for foreign-based citizens. And over the past 10 years, on an annual basis, we have the growth of HIV infection cases, but some indicators go down due to the pandemic and due to the lockdown and more active procedures of the medical entities. And nowadays we have 135,000 HIV infected. And we have Muscovites, and less than 50% are Muscovites, the permanent residents. But over the past time, the statistics registered less than 30% of permanent residents having HIV, and we have this invariable trend for the downsizing of this parameter. And the prevalence of HIV at the level of pregnant women by 8 times lower than other statistics. As for generalized statistics, and the Moscow city shows less number of HIV infected versus other capitals, and this is the picture is uneven. In the east and northeast, we have this prevalence of disease to a large extent. As to the dynamics of detection of HIV, it is more extrapolated to the migrants. And also, we have now lower indicators for HIV infections for Moscow. In the Central Federal Okrug, the level of such a disease is the lowest. Males are infected higher and more as opposed to women, and as of 1987 statistics and for 2020. And the average growth for positive tests is much higher than that of females. For men, it's more than 60%, and over the past 12 years, for women, we have this augmentation with a 0. And the dynamics identified in the mid 20th century was relying on the effect of scissors, and people over 35 constitute 80% of HIV infected. Over the past 12 years, we witnessed the obvious trend for Moscow, for the younger generation, having some new statistics. And so the vertical transmission for HIV is less than 1%. Also, homosexual dynamics goes ahead of the intravenous dynamics. And as to men, the HIV have high statistics for homosexuals, and in 2020 it's a predominating factor. The cumulative indicator for HIV is 54.014. And we have the documents verifying this mere fact. About 14,000 HIV infected died. As to the epidemiological surveillance, within certain years we had various types of surveys provided, and HIV infections are embedded in as a part of the sexual transmitted diseases, also drug abuse, and also anal sexual contacts for men and for women, and the frequency of active anal contacts is growing from the part of HIV infected, and they really incur certain risks for their sexual partners. And actually, the contraception here is not applied. And as to the classical condoms, especially for anal contacts, it's not a very regular practice. But actually, the preventive measures are not always undertaken. And the only efficient measure for preventing the HIV infection tends to be the socially safe model of the behavior of the population. And we may exclude some actions in order to minimize the number of vulnerable layers.
We have provided absolute access of the population to anonymous tests, which is free of charge. We control the epidemiological situation and the decline in the new HIV infection cases in the residents of the big city. We also see the transmission of HIV infection from the mother to child is extremely low for the modern healthcare system. Thank you very much for your attention. Thank you. Thank you. Vasily didn't cover the prevention prior to the contact. We lack this data. It is a key step in the prevention of HIV infection. The prevention prior to the contact has to be the major tool for HIV infection prevention when sexual contacts with unknown partners with unknown HIV status are risky. We have to review various opportunities, people for complete access to these medicinal products. We have this potential in our country. Each doctor of each center may provide the corresponding consultation, focusing on the algorithms of use all over the world. Still, there is no consensus in the world, like in San Francisco, Paris, or London, in terms of purchasing these drugs. And there are some corresponding discussions in our country. We do need this information, the sources of information. Maybe medical insurances will be introduced, but no one is aware of it. It's not the issue of healthcare, it's the issue of economists and those who make decisions on allocation of target funds for this work. Now we move on to the following presentation. Natalia Litvinova, Grigory Kaminsky are our speakers. Today they are the leading moderators. They tackle the Federal Register, they elaborate on it, they track the operators' work. The Federal Register works in a certain way at the level of the regions, and it's their responsibility. They have plans on the modernization of the register. There are some feasibility studies in this regard, and we'll try to switch on the application for the doctor's convenience. Now the work of the register is full-fledged. We have created this resource. We just should minimize the time limits and create the automated entry models. Natalia, can you hear us? Yes, I can hear you. Sorry for technical problems. Okay. Dear colleagues, technical service, what's happening? Whereas you are fixing the camera, we may listen to the next speaker. So we should listen to Oleg. I know that you have such a hot period. Just come from Central Asia. Thank you for Far Eastern greetings. We'll listen to a presentation with pleasure. Well, the floor is yours. Like, we are ready to listen to your presentation. Dear Alexei, dear participants of the conference, now let me start. Despite the era in which we are living, we are still responsible for our work. And now we will show the presentation, and I will focus on the prevention of drug abusers with HIV infection. This group of patients is rather challenging. But I cannot do it. I'll ask you to move the slides, and now it's the responsibility of our colleagues. I'll try to be brief. Still, the HIV infection is a somatic disease which threatens the physical existence. And for drug abusers, it's a psychogenic and stress factor causing various personal reactions which testify to the disease. And we need a sustainable link. We see the sustainable link between the drug use and the person's condition. And this link was marked from the outset in HIV infection management. The most comprehensive studies carried out by European scientists and Russian scientists show that there is a high level of drug use in the HIV-infected patients, which negatively impacts the ARVT. In 2018, over 50,000 new HIV cases were registered in Russia. They are part of the vicious circle. Unless they refer to the centers, they cannot get any medical assistance. And some of them do not follow the the treatment, and they keep using drugs. Thus, they need the full-scale treatment, which would consider this addiction. But it is impossible to comprehensively treat this somatic pathology, this somatic disease. There are some factors which positively influence the adherence, such as unwillingness to take drugs, and they may also change their lifestyles and augment the life quality. Some patients may help one another, and therefore they will be able to understand the value of the life, and they will be able to achieve new results. They also need accurate briefing and consulting and pieces of advice of the medical personnel. Some factors increase the adherence in the residents of our country. Should believe in the priority of the people who have already undergone this treatment. These information sources are of prime importance. Active involvement of equal counselors in the working process with the patients has a positive effect. The awareness of the patients of controlling ARVT also matters. Your nearest and dearest should support you, and awareness should also be raised in the medical personnel. To sum up, let me highlight that drug abusers had the following problems. The brain structures responsible for critical attitude to your condition and the motivation are affected. Thus, patients with drug addiction lack motivations and they have low adherence. Thus, our treatment should be long-term and expedient, and this will contribute to adherence. The total number of the patients who are ready to be treated in our mixed cohort and with comorbidities does not exceed 25%. After a short-term treatment, which will last for 2 weeks, we will see an annual relapse in 2 to 3% of patients. When we use the maintenance treatment for 3 months, the annual remission will be marked in 10 to 15% of cases. Next slide, please. This way would allow us to achieve the goal, and it's supporting these patients. We would like to create the conditions which would allow us to control the activities aimed at the healthy lifestyle, the course of and injections, and effectiveness and efficacy and safety are assessed at the highest confidence level, at the A1 level.
And how to apply the results of the prolonged injection naltrexone. And never before any shifts in pharmacokinetics had been registered or some side effects. we seek some kind of a consistent picture. And as it has been already mentioned, HIV infected with some drug abuse is a very complex and cohort of patients, and we need to provide consultancy to the patients and especially organizing this service of one window. With specialists, consultants, and the care workers, thus getting the competent aid. Only then the ART may be administered, thus minimizing the epidemiological base. And so interdisciplinary set of measures are to be labs at the level of hospitals, jointly done with the essential personnel and care workers. And that is the interdepartmental scheme, and with quite a number of agencies. And one of the distinguished positions are taken by the AIDS Center. And I'm not going to talk about the key goals and objectives, as it is quite clear how it all operates and who are the stakeholders here and what are the functions, what is the motivation, what is the social support, individual programs, design, the consultancy service, information service. And thus we try together with you, dear colleagues, to streamline the smooth operation of this system. And within a year, our Center for HIV/AIDS Prevention are attended by more than 800 people, and they are provided with the pertinent medical aid. I actually wanted to give you a quotation. He's the head of Rospotrebnadzor, Mr. Popov. We have two pandemics, drug abuse and HIV infection, and geographically they are conjugated. And in a nutshell, what I wanted to tell you is that we're dealing with a very painstaking contingent of patients. And the discussion is still underway as to how to administer the special banning therapy. And let me state that in Russia, all the citizens have equal rights to get free of charge medical aid and narcological as well. And we have a special R&D center to do so, to provide the service, and also free of charge AIDS center. And let me emphasize that with due regard to the effective law of Russia on the treatment of various diseases using specific drugs, it is prohibited. That these are narcotic-containing drugs, and we may some tend to say that safely drug-containing or substances may be administered as well as the replacement therapy, substitution therapy, and euthanasia. And it has nothing to do with the subject matter of our discussion. And actually, medical personnel is not required. And we are talking about the replacement of one narcotics onto the other. And the social and other type of activity of the drug addict is a myth. And we are talking about the intoxication rather than treatment of our patients. And if narcotics are administered in the course of pregnancy, they become addicted to drugs. And before the birth of a child. And from the medical perspective, it's, by the way, it is interpreted as a crime. And naltrexone is one of the substances which may actively be used for that particular purpose. And Narcological Service of the department very actively cooperates with the Urban Center for AIDS. It is an unprecedented interaction in our AIDS premises, having 20 beds, and also we have plus 60 beds in another ward, and the special consultancy services are provided for HIV infected under treatment. And the R&D Narcological Center and the Urban City AIDS put forth a special program of rehabilitation with the involvement of care workers, medical staff, and psychologists. And we have the standalone outpatient programs in subculture. And that somehow presents a motivation and gives a remedial effect, and thus our mission becomes really noble, and remission by 30 or 40% could be registered. And especially it is related to the patients with ART. And it is not as simple as that, but nevertheless, we are going to communicate at this field further, and the infected patients may be treated 100%, thus avoiding various pathological effects. That's what I wanted to tell you. And thank you for your presentations. Thank you for your lectures, and we are actively discussing all these issues dedicated to narcology, to the support of our patients with the narcological profile and unfortunately Igor Vladimirovich Pechelin will not be able to take part. I think the report is important, but the contribution of our colleagues into that research presents some kind of a bridge. This program is called Bridge, MOST. And we organize this work with the center, with the Narcological Center, and it's a part and parcel of our effort in relation to the cohort of drug addicts. And it's an absolute merit of theirs that they manage to treat people this way and which become a part of this program and who go on administering ART therapy, and that is a comprehensive treatment for drug abuse and HIV infection. And definitely that is the contribution of our partners, our colleagues who work in this MOST Foundation and who are the organizers of this initiative. And they have NGOs to join this particular endeavor, and we are very much proud of their results. They work on a parallel basis with us on a daily basis, rendering assistance to that patients. Natalia Gennadievna Litvinova from the studio.
Good afternoon, dear colleagues. Can you hear me? Can you see the presentation? Oh, we cannot see your presentation. Let me present the following topic: the role of the online monitoring system of the healthcare. The role of the online monitoring system of the Ministry of Health of the RF in combating HIV. You can see the speakers mode, but we need the demonstration mode. And once again, press this button. Press F5. Thank you. Yes, we are ready to listen to you. In accordance with the public strategy of combating the HIV infection, which has already been mentioned by Alexei, we created the register, the Federal Register of HIV. The aim of any register is monitoring of epidemiological situation in socially significant infections in the country and planning of drug dispensation. Here you can see the legal framework according to which the Federal Registers of the Federal Register of HIV and the Federal Register of TB patients were devised. It's Article 43, the Clause 43, the Federal Law 323, and it is dedicated to protection of the health of the citizens. Part 2 stipulates that in order to provide medical assistance, including drug dispensation for medical use in some patients, Federal Register is effectuated according to the ruling of the government on number 426. The following rules of management of the Federal Register of tuberculosis patients and HIV patients should be effectuated in order to solve the key functions and the key goals. And to achieve the key goals, we use the functions of the Federal Register, I mean the collection, processing, and storage of data, organization of medical checkups, drug management, controlling and management of patients with HIV. Thanks to the Federal Register, we may plan medical assistance and form analytical forms and report forms. First and foremost, we may fill in the referral to laboratory examinations in the register. The data for laboratory tests for HIV infection and for antibodies to HIV infection may be included there. And PCR is used for examining the RNA level in HIV patients. When a patient comes to infectionist, the new register entries may be opened, and then they may be linked with the referral for laboratory examination. In comparison with the forms of governmental statistical reports, the methods of which allow us to form the reports for a certain date, the methodology of forming federal register rules out duplicates when we fill in the data of the patients. We may also receive the report on a certain data and for any study period. How does it actually work? Here you can see the first page of the Federal Register where we fill in the patient data. This data is unique. It cannot be repeated for any patient. We can see the insurance report as a key identifier of a personality, the key identity document, and also the passport data. Why can no duplicates emerge? As soon as we fill in the patient's passport data, the register is working, is still operating. And when we fill in the same data for another patient, the system gives us the signal, and we won't be able to repeatedly fill in the same data for another patient or for the same patient with another surname. It's not feasible. If the patient has no key identities, such as insurance report and insurance certificate and passport data, it will not be possible to refer this patient to another region. This will allow us not to copy the information. The register only includes the patients who refer to our clinic and those who go to the doctors. We also include the incidence cases in the register, the data on patient organizations, the diagnosis under regular medical checkup, the data on newborn babies, and the data on mothers. If we fill in the data, it should have the data status at the primary registration of diseases, and they do not require any actualization. Here we can see the epidemiological evidence. The federal register allows us to carry out epidemiological control online. At any time, we may track the epidemiological situation on HIV infection. Here we fill in the data of the circumstances of HIV diagnosis, transmission pathways, and contagion sources. In order to assess the epidemiological situation over changes, we have to stockpile the data. As for the Federal Register of HIV, it started operating in 2017. Over the first years, 2017, 2019, we stockpiled the data, and now we may assess the changes in the epidemiological process. Here we can see the data of regular medical checkup. The register allows us to monitor the histories of referral of the patients from one patient organization to another one. We can also see the evidence on each patient's related to changes in the diagnosis, to concomitant diseases, to comorbidities, to dispense drugs. This register is personalized for the workers who are actively involved in patient work and who fill in the data about the patients in the register. At all the levels, the level of the Ministry of Health of the Russian Federation, the federal register is not personalized. One of the major functions of the register is medicinal management. The register includes the data about the personal needs, the regimen assigned for the patients, is filled in the register, we can receive the data on the number of HIV patients, on the patients who are under regular medical checkup, the number of ARVT receiving patients. This allows us to apply submissions for medicinal products and calculate various trends in terms of future drug provision of our patients. It will also show us that we may effectuate the treatment control, and another key function is this kind of treatment. Here you can see the key parameters which we use while combating HIV, and they correspond to represented in this table, and the BLWH receive RVT, and this allows us to assess the efficacy of this treatment. Another important issue is related to the reports about ARVT receiving patients. We may monitor each patient, and we may get the complete report in the of the situation in the Russian Federation. We may also assess the total number of patients receiving certain drugs and certain treatment regimen. Convenient. It's very convenient. Apart from epidemiological reports, this allows us to use it in decisions. And for instance, this may depend on the RVT treatment. One of the key reports is associated with the allows us to assess the fullness of for using in any region. Another interesting function of the Federal Register is assessing the retention of the patients using certain drugs. It depends on adverse events occurrence, and it is based on documented resistance. Alexei has already mentioned that many questions arise, and we'll have to solve some problems, and FR-HIV allows us to amend it and to adjust it, and we receive lots of suggestions initiated by the regions with which we're working in accordance with the ruling of the Minister of Health related to the medical documentation of personal accountability of HIV patients. Fill in this data, and the form was also of HIV patients, and they will also be amended. There will be some changes in the Federal Register of HIV, and this will allow us to upload the data. We develop feasibility studies for quick reports in real time in accordance with the key analytical indicators, including IRVT coverage and its efficacy. Therefore, the Federal Register of HIV situation allows us to assess the epidemiological situation. It is an ever-changing structure, and it changes upon our needs. Thank you for your attention. We finish. Thank you very much. We finish our session. We had enough time, but unfortunately, I didn't manage to answer all the questions. There will be a few comments on treatment coverage. We have listened to Oleg Bozik's cases. The territory work was carried out with drug addicts, and there's such a large-scale cohort of drug addicts. Is it possible to achieve this proportion of coverage in 90% of cases. Maybe it's not that possible. Sometimes we hear that we can see the coverage, but we know that over the past 3 years, no one has complained of the fact that the patients were not receiving treatment because their resources were not sufficient. We are always ready to provide this medical assistance. This issue is really challenging, thus we anticipate prolonged antiretroviral drugs. And we are now discussing it. It's the key topic for our discussions. This element of working with these patients is vital. We should expand the coverage without undermining the quality of treatment. And the National Virus-Related Association, which I have already mentioned, includes over 500 participants. There is also the International Council in this organization. This zone is fairly open. You may enter it. You may exit it. It's like Clubhouse, but even in Clubhouse you'll need some presentation. But we are ready to welcome all of you. It's related to the leading scientific centers of the world. You'll have a chance to undergo internship on certain issues in different corners of the world. We have this opportunity. There are also some publications in this domain. Today we give points for participation in our seminars. Thank you very much. Thank you, the organizers. Another example of this dialogue is cooperation is indispensable nowadays. It guarantees the success of our work. In the COVID-19 era, we've learned a lot of lessons from this pandemic. This tragedy takes place, but the virusologists became friendlier and the world is safer. Thank you very much for your attention.
понятно, да, что было? Он восстановился же, да, потом?
Да, само собой, просто восстановился, все, фиг пойми. У меня мог еще зум на телефоне затупить.